We are live now.
Yeah.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on female sexual health and dysfunction in midlife and menopause, organized by Chennai Menopause Society. So, it's my privilege to introduce the MOC of today's webinar, Dr. Bharani Ma'am. Ma'am is the senior resident at Sri Ramchandra Institute of Higher Education and Research, and Ma'am is the member of Safe Motherhood Committee, OXI. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, and a very good evening to one and all. I'm really happy to be the mock for this seventh webinar of Chennai Menopause Society. Today's theme is female sexual health and dysfunction in midlife and menopause. Women spend over 1/3 of their lifetime in middle age, and to address the different dimensions of their sexual health is of paramount importance. So today's webinar is going to entail that. I request our President of Chennai Menopause Society, Shanti Gunasingh ma'am, to welcome one and all. Shanti Gunasingh ma'am is a consultant in Mangalam Healthcare, Chennai, President of Chennai Menopause Society, past President OXI, former Director and Superintendent IOG, ISO KGH, and HOD of Kilpauk Medical College. Over to you, ma'am.
Thank you, Bharani. It is indeed my pleasure to welcome the esteemed faculty as well as the delegates who have joined for this our seventh webinar. We know that dysfunction in sexual dysfunction in midlife is quite common, and both the practitioner as well as the patient or the woman rather are not forthcoming about it. So both do not feel comfortable discussing this vital issue. So to talk on this, we thought we will have a whole webinar on that, and we have great faculty for that. And I'm really very happy to welcome Dr. Sushma Chawla, Honorary Professor of Dawn ICMCH and Director Chawla Nursing Home and Maternity Hospital. Madam, it's indeed a pleasure to have you here, Madam. And it is nice to have Dr. Yarini Selvaraj, the dynamic Secretary of Madurai Menopause Society. Tamil Nadu seems to be really quite active in IMS, I think. So welcome. So it is nice to have her as the guest of honor. We are really very proud to have both of you all here. I also welcome the esteemed faculty, the chairpersons, Dr. T.P. Kanagu, our dynamic secretary, Dr. Meera, Premalata, Dr. Radha Madhavi, and the speakers, Dr. Vidya Bandukwala, Dr. Karthikeyan, and Dr. Sanjay Pandey. And we also have our Dr. Jayarani, President OXI, as moderator, with panelists Dr. Rajapriya, Dr. Karthikeyan, Dr. Deepa Ganesh, and Dr. Sumati Anand. Welcome to one and all, and I think we will go on to the program. Thank you.
Thank you, ma'am. We will begin with the Tamil Thai Varthu. Following this, we'll have the virtual lighting of the Kuttu Velakku. I now request Kalevani ma'am to read the midlife prayer. Madam is the director of IOG Government Women and Children Hospital, Egmore, past director of ISO KGH, UG PG teacher for the past 26 years. She's conducted workshops on basic obstetric skills and emergency obstetrics in various forums, and Best Doctor Award by the Tamil Nadu MGR Medical University in 2018. Over to you, ma'am, for the midlife prayer.
Thank you, Bharani. Midlife prayer. We pray to God to give us grace to accept the midlife physical changes and gently renew our strength. Guide our heart, our mind, and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women, and inspire us to give us this gift of hope to others. Thank you.
Thank you, ma'am. I take great honor and privilege to introduce our chief guest for the day, Dr. Sushma Chawla, gynecologist and obstetrician, laparoscopist, hysteroscopist, colposcopist, and IVF expert, honorary professor and dean, Dr. Dawn ICMCH, Chawla Nursing Home and Maternity Hospital from Punjab. Madam is the president, Narchi Jalandhar branch, chairperson, maternal and child health, RI district. She was the president of IMA Jalandhar in 2014, member of Juvenile Justice Board and Child Welfare Committee, Vice President Arya Siksha Mandal, Kanya Mahavidyalaya, Sanskriti KMV School, and she was awarded the North India Gynec Forum for Oration in December 2022 and Lifetime Achievement Award in 2016. Ma'am has plenty more awards in her kitty. We're very happy to have you with us today, ma'am. I request you to kindly say a few words and also release our Muddle 7, which is our e-magazine this time.
First of all, I thank all of you and the president, for inviting me for such a august gathering. It is a pleasure to be with all of you, all highly placed and very well doing in your practice and looking after the menopausal society as well as the midline life. I think it is a very important topic. Perhaps we have been talking about the Alzheimer, we are talking about the heart diseases, the paralysis and the osteopenia, osteoporosis. Once I went to Holland, I was attending the World Menopausal Society, and in a very big board, it was written, break the silence. I didn't know what it meant, break the silence. But it was all about the sexuality in the midlife as well as the menopausal women. So it is something which we commonly don't talk. And I think in our Indian scenario, it's something which everybody keeps quiet. I think it is for the doctors to initiate the topic on sexuality. Then only the patients really come up and tell what exactly they suffer in silence. I think it is a very important topic, and I congratulate you for initiating this topic and making people aware of it. I think we are going to have a very nice talks about this subject, and it is a pleasure, inaugurating your newsletter, Mandal, for this occasion. Congratulations. I think we can go on to the next sessions. Thank you very much for inviting me in this August gathering. Thank you so much.
Thank you so much, ma'am, for your kind words. And this is our Muddle 7,
So,
little sneak peek.
So, KYC, know your city, very nice. So you go. Awareness about healthy aging, excellent. Know your society, and this is Kollam Corner, very nice. So congratulations.
Thank you, ma'am. So, moving on, I'm also privileged to introduce our guest of honor, Dr. Yarini Selvaraj. Can we have Madam CD, please? Madam is a former Assistant Professor of Obstetrics and Gynec Department, Madurai Medical College, Managing Director, Madurai Pune Fertility and Research Center, and Chief Consultant Gynecologist and IVF Specialist. She's practicing fertility treatment for the past 20 years, and she's also the Secretary of Madurai Menopause Society. Madam has more than 350 presentations in both national and international conferences, received many awards, especially the Amazing Woman Award from the Women Entrepreneur 2015, Bharat Ratna Dr. APJ Abdul Kalam Excellence Award, Mayan Award 2018 at Malaysia, and Best Clinical Paper Award for Sclerotherapy for Recurrent Endometriomas Fertivision 2019. We're very happy to have you here, ma'am. We'd like to hear a few words from you and also release our the Chennai Express 3.0 in this session.
Thank you so much for your kind words. And I am very much honored to be invited by the Chennai Menopause Society. It was very gratifying to see you all in one platform. I traveled for more than 24 hours from states. Yesterday, only I reached Madurai. And when I was there, Dr. Shanti Gunasingh, she called me and she wanted me to be the guest of honor. So I'm so privileged. And I thank Dr. Shanti Gunasingh, President of Chennai Menopause Society, Dr. Meera Raghavan, Secretary of CMS, and Dr. Kalaivani, Treasurer of OGSSI, for inviting me as guest of honor. This webinar will definitely enlighten us on female sexual health and dysfunction in midlife, as well as menopause. As Madam Shushma told that we have to break the silence by this creating an awareness about this less spoken problems of menopausal women. During menopause, the sexual function worsens with advancing status. Declining levels of sex steroids like estrogens and androgens play a major role in the impairment of sexual response. The most frequently reported symptoms like low sexual desire, even after the age of 40, that is around 40 to 55% contribute to this low sexual desire, and poor lubrication, which is contributed by 25 to 30%, and 12 to 45% contribute to dyspareunia, maybe due to the lack of lubrication as well as the genitourinary symptoms, which are very common around the perimenopausal age. And these symptoms lead to major impact on menopause and perimenopausal women, creating a stressful environment. It's time to think about it. The greatest kudos to Chennai Menopause Society for arranging this wonderful webinar with eminent speakers and omniscient panelists. Thank you once again for inviting me, and wish you all the best for this wonderful webinar.
Thank you so much, ma'am. We'll also have the release of Chennai Express 3.0. We had an amazing mid-year conference on the 3rd and 4th of February earlier this month. And these are some snippets from the workshop and the conference.
Yes, it's a wonderful thing that Chennai Menopause Society is doing their best under the guidance of Dr. Shanti as well as Meera and Dr. Kalaivani. I wish you all success and all the best. I hope you will be fetching the Best Menopausal Society Award during the coming years. I wish you all the best. Thank you once again for giving me this opportunity. Thank you so much.
Thank you so much, ma'am. We will move on to our first scientific session. For all the delegates, we have an exciting quiz at the end of the scientific sessions, which you can take as an online poll. So stay tuned and listen very carefully. So we'll have the first scientific session, and I take great privilege in introducing the chairpersons for our first session. Dr. T.P. Kanaga ma'am. Ma'am is was an assistant professor in OG at Government RSRM Hospital and IOG. She's a member of ASRM, ESHRE, ISG, IAG, FOXY, OXY, and ISAR. Her areas of interest include endoscopy and ART, high-risk obstetrics. She's currently the director of KM Hospitals and IVF Center, Chennai. Welcome you, ma'am. Our next chairperson, Dr. Meera Raghavan, ma'am. Ma'am is a consultant urogynecologist and robotic surgeon at Apollo Hospitals. She's a board-certified lifestyle medicine physician, National Board Specialist Committee member, and National Board Coordinator and Examiner, MRCOT trainer and examiner. She's also part of the Apollo Simulation Center coordinator and director for obstetric skills course, winner of 32 gold medals in undergraduate and best outgoing PG student from PGIMR Chandigarh. And she's also the secretary of Chennai Menopause Society. Welcome you, ma'am. And Dr. P.B. Premalata, ma'am, HOD and Professor of OBG Department, Tagore Medical College and Hospital, retired Professor of MMC and KGH, Project Officer KGH, 28 years of teaching experience, done more than 100 adolescent programs and cancer screening programs. She's present at Taper and FIGO International Conference. We're very happy to have you too, ma'am, as the chairperson. We'll move to the first scientific session. Thank you, ma'am. And I request the chairpersons to introduce our speakers.
Yeah, good evening, everybody. Female sexual issues and dysfunction in midlife and beyond. Break the silence was what our chief guest said, and that's very true because this particular topic, female sexual issues, is neither talked about by the patient much nor the gynecologist easily. And this needs more open fora. And here we are, where Dr. Shanti has started this forum. And I welcome Dr. Vidya Bandulwarka, Director of Touch of Joy Women's Clinic and Fertility Center, Consultant, Saket Maternity and Nursing Home, Nalavati Max SSH. Affiliations is she's founder member of Female Pelvic Pain Association, core member of Global Interstitial Bladder Pain Society, and managing committee member of AFG, Associate Fellow Gynecologist. I welcome you, ma'am, for this wonderful talk, which we are hoping from you.
Thank you
The
so
stage
much.
is yours.
Yeah. Okay, now I will share my screen. Yeah. Are you able to see?
Yeah.
Yeah.
Yes.
Yeah, we
Okay.
can see.
Yeah, thank you so much. So before we start this, thank you so much to have me around. Thank you, Dr. Meera, Dr. Shanti, and the Chennai Menopause Society to have me on this very, very sensitive topic today that we are going to discuss. And I totally agree with Dr. Sushma Chawla that we need to break the silence and we need to emphasize on the sexual health of a woman in her midlife. Now, before we start, I've put this picture on purpose, is one to realize that this couple, it's showing a picture perfect of a couple who are so happy together. And this is only a reflection of a good physical health, psychological, mental health, as well as a sexual health. And this is what we as gynecologists should be able to give back to our women. So let us begin to understand what is midlife and menopause. And I agree that there are a lot of changes that we see in this phase of midlife going on to menopause. We see a lot of decline in the ovarian function and hence the decrease in the sex hormones, the estrogen, and with the aging, the androgens. And all these have a negative repercussion on the health of a woman and more so in the sexual health. And as we know that it has been a stigma, it has been a taboo for a long time for women to speak up about this sexual health issues to us as gynecologists also. Now, middle life, it spans from 40 to 65 and onwards. Now, with the advent of newer medical facilities, preventive healthcare, we are having a longevity of life. And hence, women, almost 1/3 of their life is spent in the middle life and menopause. And hence, it is very important for us to address these issues in the middle life. Now, why is it challenging for women? Because in middle life, we see a lot of biological changes along with the hormonal changes and the psychological component, because women are multitasking today. They are no more just homemakers, but they are also out working and have work pressures. They have relationship issues. They have children who are growing up and getting into the adulthood with their tantrums and their educational background. And today we stand hand in hand with our man, taking care of the family financial burden. So it is very, very important that to cope up with this multiple co-stresses along with the physical and physiological aspect is very, very important. So why are we talking about sexual health? So as WHO said very nicely, that it is very important for a state of physical, emotional, mental, and social well-being related to sexuality, so that it's not just the part of a middle age or anything, but it is the basic human right to have a good sexual health also. And also, I realized that healthy sexual function is just an integral part of a human experiences, and it also helps us to get an emotional connection and intimacy and relationship satisfaction. So it is very important for us to have a good sexual life. One second. So why do we need to understand female sexual dysfunction? It is very important to understand because female sexual dysfunction in midlife can significantly impact the quality of life by causing emotional distress, which we are seeing that there is a persistent recurring problem with sexual response, desire, orgasm, or pain. And this is the main complaint. Any personal distress or partner distress is the important diagnosis of a female sexual dysfunction. And it can lead to not just emotional distress, but there is a strain in partner relationship and hence a complete diminution in the overall health of a woman. This can lead definitely to frustration and a low esteem in women. And also, we have to realize that as we are aging, there is a lot of physiological, biological changes that are also changing in a woman. And we can land up with comorbid conditions like the metabolic and cardiovascular, which can exacerbate and impact on the sexual health as well. These components then come to the mental health well-being and leads to anxiety and depression in women. And these are more so commonly seen during the midlife and beyond. This is just a pictorial understanding of what a woman goes through in her daily life. It could lead to changes in her relationship with her partner, with her children, her school, her work pressures, her financial stability, her disturbance in sleep, because we see that as we age, we are seeing a lot of disturbance in sleep pattern because one of the genitourinary system, as well as the night sweats and hot flashes that she undergoes with the menopausal change as a vasomotor part getting affected. So these are all important parts when we are addressing a woman with sexual dysfunction. What is the prevalence that we are looking? Yes, we know that sexual function worsens and it advances with the menopausal status, and 45%, almost half of the female population has sexual dysfunction, and 15% have a sexual issue that causes significant. So you can imagine 15% of the women have significant, and there are so many hidden percentage that is not even come up to tell us about the dysfunction that women are going through. And what are the frequent symptoms that we see? We see low sexual desire, almost half of them have that, poor lubrication, and dyspareunia. This is one of the most bothersome and the complication part of genitourinary syndrome of menopause. We know that declining estrogen levels can lead to vulvovaginal atrophy, changes in the elasticity, soreness, and leading to genitopelvic pain that we need to address at this point. We also now need to know what is the sexual cycle response. Unless we don't know the response or the cycle, we will not be able to evaluate the sexual dysfunction. So let us understand the effect of dopamine and serotonin here. They both have the excitatory and inhibitory centers. And we also should now realize that those people, those women who are on antidepressants, this is the serotonin which leads to inhibitory changes. And that is why they have the side effects of sexual desire and arousal. So we have to be sure about her medication and treatment while evaluating a patient with sexual dysfunction. So let us understand what is the cycle. It starts with the desire, which is a very subjective feeling, an inclination to a sexual act, and it is driven by the neuroendocrine system, leading to excitement and then going into the arousal phase, which is more erotic with the changes in the inner two-third vagina, increasing length with enlargement of the clitoris, and this is all the parasympathetic nervous system. And here is where there is lubrication, which is the wetness in the vagina, followed by the peak of the action, that is the myotonic part of the process, where there is complete increased tension in the pelvic muscles, there is tightening, congestion, and at the same time, there is an increase in heart rate, blood pressure, and respiratory rate increases because of the sympathetic pathway. So you have to understand that all these pathways, the parasympathetic and the sympathetic and the neuroendocrine, all are working towards one sexual response. So anything can be impacted. So it is very important for us to understand and evaluate a case. And the end, the culmination of this response is resolution when there is complete relaxation and reversal of all the changes that we have seen. So it is very important that we address each component very differently and take it forward. So what are the types of dysfunction? Unless you do not know the sexual response cycle, you will not be able to evaluate this. So we have to realize that there could be disorder in the desire, in the arousal, in the orgasmic disorders, and the sexual pain, which we usually see in the genitourinary syndrome of menopause, because here we could see that women can have desire, have arousal, but are not able to function because of the pelvic pain that they are going through. And this is the most common and bothersome symptom of the menopause. What are the factors? We already know that the declining level of the hormones can lead to a lot of genitourinary atrophy, and hence we find that these women have vaginal dryness, decreased lubrication, which affects their desire, arousal, and a very painful sex. Also, we have to note that with the aging comes a lot of physical changes, which are seen in the form of weight gain. And a lot of women, it is not a welcome sign for a lot of women, because that is also a stress. Her body image is changing in the society, and that carries an impact on her mental health. Also, the comorbid conditions that we see, the metabolic and the cardiovascular system, or patients who have cancer issues that they need to work on. So these all can have a negative impact on the sexual health. Also, as I said, that parallelly, when we are talking about the hormonal changes and the physical changes, we're looking at the psychological factor, because these go parallel in the stress, the anxiety, and depression, all leading to a decrease in the sexual drive, desire, and overall well-being of a woman. The most and the crucial part in any sexual dysfunction is her relationship dynamics with her partner. So we have to understand that women at the middle age could have a lot of, some women can have relationship issues, some may have separation from their partner, or some may have a loss of their partner. So it is very important to evaluate in the history about her partner, because this is a crucial point to know about sexual dysfunction. And these changes are very important, especially those who have partners. There can be change in communication and bonding, and these changes works on the emotional factor, psychological factor of the women, and she can then have a negative impact on her sexual life. Again, as I said, that medication is very important to know, because certain medications like the antihypertensive and antidepressant are cause a depress or suppression in the sexual action, and that impacts the health as well. And also women who have undergone chemotherapy or radiotherapy can also have side effects which can work against the sexual health. So what are the types of female sexual dysfunction that we are looking at? We have to realize that sexual disorders like the desire, arousal, they are all interconnected and inseparable. So we cannot put one before the other. It has to be evaluated in total while we are dealing with a sexual dysfunction patient. So this is the most important criteria of diagnosis, the DSM, which stands for Diagnostic and Statistical Manual of Mental Disorder in Patients with Sexual Dysfunction. There are the components, which is the female sexual interest and arousal disorder, the orgasmic disorder. The most important, it was there in part 4, the edition 4, which was dyspareunia and vaginismus, which is clubbed together as genitopelvic pain and penetration, because this is a progressive disorder, chronic progressive disorder of genitourinary syndrome of menopause, and if not recognized and treated at time, can be very debilitating for a middle-aged woman. So it is so very important to know this DSM edition 5, and to diagnose this, the woman should have the symptoms, or she should experience the symptoms for at least 75 to 100% of times, and for at least 6 months or more, and it should have a significant distress in her or her partner to be labeled as a sexual dysfunction issue. Now, this is a validated questionnaire. It's very important that today, with women not able to speak up, at least we can have questionnaires where they can read it and they can, reply on the questionnaires of yes, no, and it depicts all the physical attitude of a woman, her mental status, her past, her present, her relationship with her partner, all coming in one paper with a yes or no, so that we can evaluate it just by looking at the paper. So we do not lose a lot of time, and we actually allow the patient to speak up for her own issues. So this validated questionnaire should be there in all office setting of a gynecologist who are dealing with sexual health dysfunction. This is one of them. There are a lot of other questionnaires which are available on the net. Now, why are we saying that female sexual health is such a big issue? Yes, it is a challenge because we as Indians take it as a taboo to speak about sex. And this is the stigma that we are carrying forward. Also, there is so much of lack in awareness and understanding, not just in the patient, but even in us as a gynecologist or any of our healthcare providers. We also do not probe into the sexual life of our patient. But as of now today, the International Menopause Society has strongly recommended that we must initiate the conversation of sexual health in the beginning of a menopause. We have to prepare the women. We have to let her know that these are the consequences of menopause, and she should be prepared to accept it, because a proactive mindset of a person who knows what is going to come forward, she will be more prepared to accept it in a long way. So these feelings of embarrassment and shame should be taken out. We have to have forums like this, not just for us as healthcare personals, but also to the masses, so that they understand this importance of sexual health in their well-being. The impact is definitely on a person, self-esteem, and the mental health, which is very, very important in any women of middle age. Now, how do we diagnose? As I said, there are a lot of questionnaires. There is the DSM edition 5, which help in the diagnosis. But most important is a one-to-one talk with the patient who's undergoing such a issue. It is such an intimate issue that women are very, very, very ashamed or embarrassed to come up and speak to even their own nearest loved ones. Somehow that taboo has to be taken out, and I think we can do a better job in doing that. So evaluation should be not just on the hormonal aspect, but at the same time, a person should be evaluated wholly, considering her physical health at that moment, her psychological mental status, all together with her emotional relationship with her partner, all put together. It's a comprehensive assessment. History is a very, very important part of any evaluation. So history and physical examination. Physical examination, we all know that there are a lot of atropic changes that we are seeing that should be, looked upon. There is no particular laboratory tests, so let's not speak on that, but the psychological aspect is very, very important, and we have to realize that the diagnosis has to be validated with a proper questionnaire and to know exactly what kind of sexual disorder she is going through. Again, as we said, that once we are diagnosed with the sexual dysfunction, it's very important to collaborate with the right faculty or right colleagues so that the patient who is undergoing a lot of hormonal changes, a lot of fluctuations in the hormones, which are also commonly seen in the genital urinary. So these women not only have vasomotor issues, but they also have urinary issues, which keeps them awake in the nighttime with nocturia or bothersome frequency urgency. And all this has to be worked in parallel with the treatment management. So initiating referral to the urologist or a psychologist and a sex therapist is very, 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 very important. Psychological factors, I've already spoken, that impact the sexual is again the depression, anxiety, her own body image, how she perceives herself is so important. The environment, the situation that she is, she probably may be looking after an ailing parent or an ailing partner or a situation which is stressful for her, all can impact her mental stability and her sexual health. Again, culture of stigma and taboo has to be taken out, and we have to come out of it. Relationship, commitment, and duration, very, very important and crucial part in the management. But last and not the least is the childhood sexual abuse. That is very important. Why? Because any childhood abuse can negatively impact on the sexual health, and we definitely need to probe into the sexual health of childhood too. Now, when we say that we need to address this, we need to address this because today, as women do not come forward to speak about speaking to them and addressing them and initiating a conversation will help them. And while doing so, we can help in their physical and mental stability, their relationship satisfaction, a sense of identity that everything is going well with the woman, and an overall sense of fulfillment, happiness is what we are looking forward by addressing sexual health in middle life. What are the treatment options? The treatment options are always a holistic approach in sexual health. And that holistic approach also means that we are looking at a pharmacological and psychotherapeutic counseling in hand to hand. That means they parallelly work together at a go. And we must try to change the lifestyle, whichever is modifiable, in the form of asking her to exercise, decrease her stress levels, have a good diet, and all this. But we have to remember that every sexual dysfunction patient can have different symptoms. Some can have more vasomotor symptoms, some can have more genitourinary symptoms, some can have more of anxiety, depression. Each one has to be individualized and tailor-made for her specific needs and her preferences, with the perspective of biopsychosocial approach is what we must negotiate with her. Again, today with the women in the smoking and excessive alcohol consumption, we have to tell them that cessation of smoking and moderation in alcohol and an active physical lifestyle can all work well with the health and sexual function. Menopausal symptoms, we've already spoken about it, but see how it disrupts the sexual desire, arousal, and satisfaction. Again, social and cultural beliefs are the most pivotal part of our society, and how they work against us is very important. So education is important. Education about the menopause and sexual health can change the women's attitude and her experience related to the sexual function. Interpersonal, again, it's a part of the, it's a part of the sexual function. Again, we have to know the psychosocial. The psychological treatment involves the CBT, that is the cognitive behavioral therapy. A mindful therapy makes a person aware and accept the sensation and emotions and thoughts and focusing on the sexual act while in the act. So these are very important. Couples and individual therapy is so very important, because unless you know your couple, the partner's issues, which are also a part of the system. That means if a partner is also aging, he also has comorbid conditions, we must be able to address it, because men at their age of middle age can have erection dysfunction, they can have premature or delayed ejaculation. All this can impact on the female sexual health. So as a female partner, we have to learn and teach them to be a more supportive partner, so that there is emotional bonding and acceptance of the issue, and to help the partner meet an andrologist so that he can be addressed and helped in the management process. So couple and individual therapy also work as a crucial part of the treatment. This is exactly the what I was speaking. Here, the therapist can communicate and help to provide tools to enhance intimacy and address the emotional barriers. Now, why do we need to counsel our patient? Patient counsel is very, very important. And we have to realize that our patient expect us to have them as a confidentiality and a private affair. They would not like even a third person sitting across the table. So we have to respect that in women. 70% of the patients prefer. This was a work done by an Indian, Dr. Kaldra, who actually gave this, that why patients want a counseling and they are more comfortable with a gynecologist. A female counselor is more accepted and they would like to be spoken in their local dialect. So supportive resources are all available on the network and internet. So we can give them that. Now let us come to the treatment part. The very important part is first to understand and diagnose and treat the sexual dysfunction by addressing the modifiable factors. Here we know that just educating them and making them understand and just imparting knowledge about what are the treatment profiles and options that are available, and to also involve the partner when it comes to an emotional or mental instability in the partner relationship. The mild and symptoms where there is contraindication of hormones, there are non-hormonal. We know that there are vaginal lubricants and moisturizers. The laser therapy has now come into the spotlight with the help of laser therapy. The carbon dioxide lasers and the YAG lasers have helped in increasing the collagen and elasticity of the vagina and help in the vaginal health. Pelvic physiotherapy is very, very important in those women who have laxity of their vagina or they have that mild, pelvic organ prolapse. These can be helped. Women with a narrowed vagina can be helped with dilators. And of course, the therapist and CBT can do their work. When it goes to the moderate or severe form, where we need to use the local form of hormonal application, there are the local estrogens. The newer ones are the progesterone, which is a DHEA. We have to understand that once it is applied vaginally, it is converted into estrogen and androstenedione, and it takes care of the vulvovaginal atropic changes. The transdermal testosterone, we always thought of estrogen as the female hormone, but it is come to the highlight that testosterone works in and has a synergic effect on the female sexual act along with the estrogen. So testosterone has given us very good results and is now there are a lot of new emerging applications, local as well as systemic, that we can think about. And the last but not the least is the moderate to the severe dyspareunia, whom cannot be given local estrogens. There are the SERMs that have come up, the selective estrogen receptor modulator, or the tissue selective estrogen complex, which is a pairing of conjugated estrogens with the SERMs. These are all very promising, and I think it will soon be a product that we will all be using very, very normally, like our other products in obstetrics and gynecology. This picture is something I just wanted to know, that we were only talking about India and how we are lagging behind in our stigma about sexual health and speaking about it. But even in a country like America, there are issues. Can you imagine people are experiencing a gap in understanding the importance of sexual health and comfort? So if people in the most developed countries are not able to come forward, I think India is still far behind. And it should be a challenge that we should take in imparting knowledge to our patients, and let's bring, there should be a breaking of the silence. Let them speak. They have to speak for their own self. And these are the things that I wanted to just highlight to all of you all. So let us look at women in the middle age with a lot of respect and encourage them to prioritize their sexual health, seek help at the right time so that we can recognize and we could manage and help them to to work for their own health of a female of the sexual dysfunction. Also, we must hold destigmatizing discussions about sexual issues within our society, not just with the healthcare personnel, but even with the masses. We should empower our knowledge and education about sexual health and always give them options of the treatment with their personal preferences. Always set realistic expectations about the symptoms, and we must know that there are certain symptoms that improve with the period of time when the body adjusts to the hormonal changes, but there are certain symptoms that can only progressively get worsened, and these are the symptoms that has to be recognized at a given point and brought to our notice. So the overall understanding is we should reduce the stigma of sexual health around menopause and give back to our society a good understanding of sexual health so that they can have a satisfying and fulfilling life and an overall well-being. So before I end, and before a patient says, I need more lubrication, let her first ask, I need my gynecologist, because as a gynecologist, we can help her with her issues, the most intimate issues, which she is so embarrassed and ashamed to speak about. So let us make them more comfortable with a one-to-one talk in confidentiality, and hopefully help many more. I truly like the prayer that we just read through. It so much means that we as gynecologists should feel like a messenger in doing so. So let's all hold hands and pledge for this. Thank you so much.
Thank you, Dr. Vidya. That was a very extensive talk that you had given, really putting light on the whole issue. And as gynecologists also, it has made us realize that we should be more practical in the whole thing, make it more easy for the patient to approach us and give them the proper ideas, holistic approach. And whenever needed, the other partners in our field, the urologist and the psychologist and the sex therapist, when necessary, called upon.
Yeah.
Thank you so much.
Thank
for
you.
your
Thank you.
wonderful talk.
Excellent.
Thank you.
Very nice.
There is a question in the chat box. Patni, can you, or Hannah,
I can't see.
for
So the
therapy?
one question that we have is what exactly is cognitive behavior therapy? Can you please give one example in reference to a case of vaginismus?
So when we look at vaginismus, as I said, history taking is very, very important. So we have to know her past history. So when we look at vaginismus, we are looking at her having irregular contractions in the vagina with just the thought of penetration. Now, this is very much a psychological component. So in CBT, they actually help you to overcome that feeling. And we can help them with graded dilators and all, because sometimes they may be in your office setting and you're able to put your ultrasound probe and they may not feel anything. But when they are in a sexual act, they are not able to perform. So the psychologist and the gynecologist work together, and we need to probe about their childhood trauma or whether they have any issues with their partner. Because as I said, sexual act is not just about, it is also a psychological and emotional component and her relationship with her partner. So it's very, very important. Again, vaginismus as a primary or secondary is also very important. So CBT works wonderful in such cases.
Very nice.
I hope I have given the answer rightly.
Very nice.
Thank you. Thank you very much.
Excellent.
Thank you. Thank you.
Thank you. We should go on to the next speaker.
We would like to invite Dr. Karthikeyan, microsurgery andrologist and urologist, Apollo Hospitals. He's our very dear colleague from Apollo and has really transformed the Department of Andrology. In fact, a pioneering work is being done. To present to you all, Dr. Karthikeyan. He is a council member of USI Andrology Section. member of Global Andrology Forum, USI Collaborative Research Panel, editor Men's Health Society of India, and founding convener EOSI Andrology Section. And he's got various gold medals to his accolade and has started an array of procedures in the andrology department, including micro-TC, evaluation and treatment of hormonal disorders, oncofertility and fertility preservation, evaluation of erectile dysfunction, and we did the first penile implant and the prosthesis as well. It has been a fantastic stride in the management of sexual dysfunction and erectile dysfunction amongst men, and therefore great service for the population as well. So welcome, Dr. Karthikeyan, and we look forward to hearing from you.
Good evening, madam. Thank you. And thank you, the Chennai Menopause Society, President, Secretary, and all the faculty here for giving this opportunity to present our work. So I'll just share my screen. I think my screen is visible.
Yes, it is visible, but full screen will be
Full
better.
screen.
Yes.
Okay. So good evening, everyone. And this topic is going to be male sexual issues for women in midlife and menopause. So thank you, Dr. Vidya, for setting the stage for this topic. So we have already gone through a lot of things which we do and we see as male men's health consultants and andrologists. So these are going to be a parallel repetition of the male issues. So I won't be going into the things which already Madam has dealt with, but it is just to understand that the last slide which Madam had put, the lube versus the gyno. So it is the same thing which we are also facing, and a lot of times men and women do not understand or have not understood about these things even till 13-15 years. So to quote 2-3 examples, we see unconsummated marriages in the midlife. So 40 to 60 years, even at 40 years, we get patients with unconsummated marriage. We see people coming in with second marriages with unconsummated marriages. So that is still more surprising. And we also see men or couples who come with, say, reduced satisfaction because of premature ejaculation, where the male partner or the female partner do not understand the importance of foreplay. So these are the couples whom we are seeing, and that is why we have this topic here. And we also understand one more thing where women experience a lot of issues around menopause, but we have similar thing as andropause and those things in the men. So as we rightly discussed, it is a time spanning at 40 to 60 years where the man undergoes through physical, emotional, and psychological changes. Only to, like, once they cross this period, then only comes actually the last, say, years where it is considered to be the best year, because the work for which the man has reached the year that has completed, and now it is time for them to enjoy. But then that is the time when these issues crop up, and that is where we come into the picture of these patients. So the midlife crisis is a more intense experience of these changes, which can lead to dissatisfaction, anxiety, and a desire for major life changes. So what are the key aspects which we see? So men in midlife may start experiencing physical changes, which can lead to decreased energy levels, changes in sleep patterns and weight gain, and also hair loss. So they think a lot about these things, and they are also more at risk for developing certain health conditions like heart disease, diabetes, etc. There are also some emotional changes, which are a feeling of stress, anxiety, depression, and they also sometimes start questioning their life choices and their sense of purpose. So this is what I was mentioning. So at this point of time, when they know or they're looking at the best years, these are the things which come up because of multiple reasons, maybe financial, maybe relationship issues, maybe stress in work. As they grow in their career, so they undergo a lot of, there is a lot of good thing happening in the career, but that parallelly affects the overall quality of life. So that is what again starts happening, and they start questioning about their identity, And with the problems like erectile dysfunction, libido issues, they even start questioning about their masculinity, and they start to think more about their mortality and with the passage of time. So that is what level up to which these things can impact a man's life. So the midlife in industrialized versus developing countries, again, there may be a slight difference, because in India we see, even though the definition is 40 to 60, there are some definitions which even tell around say 50 to 70 or 60 plus. That is the midlife. The only reason, because in India, maybe when compared to the Western world, the people start becoming self-sufficient and really good position in their lives, maybe still later. So till that time, they are expected to toil to improve their own standards and all those things. And by the time they reach a situation where they are self-sufficient, probably there are so many issues which already happened, so that sex is either forgotten, or they come to a situation where they think that this won't happen henceforth. So the female issues like dry vagina and all those things are being addressed nowadays in a more systematic fashion, and we have so many specialists like you who take care of these things. And these are the patients who now then we come to the idea that there is an erectile dysfunction or premature ejaculation, which is mainly affecting the relationship. So we start getting referrals from gynecologists and menopause experts like you, who refer patients with these symptoms, and we uncover that they have been suffering these issues at least for 10 to 15 years. The male comes and says that my wife doesn't have interest. But when we put back the question, if we improve your erectile dysfunction or say sexual issues, will your wife get back the interest? They immediately tell yes. That simply means that male sexual issues can impact female sexuality, and we all know about it. So the signs of a midlife crisis are increased sadness, mood changes, ending plans or giving up, frustration, irritability. These are all the symptoms of testosterone deficiency as well. But as we see many patients who overcome with these symptoms, they usually don't have a testosterone deficiency. But today the patients are themselves coming and telling that I have testosterone deficiency, my symptoms are testosterone deficiency symptoms. So that is where the media and the internet is giving an impact, but they have the wrong ideas and wrong conceptions. So reduced libido, erectile dysfunction, PE, scrotal content pain or testicular pain, pain after ejaculation or prostatitis. These are the most important men's health issues we see. And they have also some issues like delayed ejaculation, reduced ejaculate volume, and loss of morning erections, which may be psychological or organic. So these are the symptoms which lead to these problems. And the reasons being physical health conditions, testosterone deficiency or other hormonal issues, and psychological factors which we just discussed, like the stress, anxiety, depression, and relationship issues. So these are the conditions and reasons why these problems happen. Medications like antidepressants. So the world is stressed today. We see a lot of patients coming in with the word stress and depression. When we ask why you are stressed, they don't have an answer. It's so common and so confusing for us why these people get depressed. We see patients being rampantly prescribed with antidepressants and these drugs. They also have a lot of stress, and that even leads to hyperprolactinemia in these patients, which again causes libido and ejaculatory issues. So this is the cycle which is happening, and we really don't know which started first. So that is the depth of the discussion and the counseling which happens in the andrology OPDs. And as madam also mentioned, smoking, alcohol, etc. are playing their part. So the newer issues, as I mentioned, is second marriages. So typically the male is 45 plus and the wife is around say 40. And late marriages, so where they get married at 37, 38, and they again look at their career and they come to us at 40, 42, where all the eggs have gone and the sperms are in the phase of like going away. So infertility, again, we see patients coming with 17 years, 20 years of infertile life, and they come at the verge of their say the poor AMH and the poor sperms, and at that time they want treatment. Again, there are some patients who come with reunion, so they have gone apart for 10 years and they again come back, and now they want to have a marriage, have a sex life, which again is too late for these people. So these are newer situations. Maybe a westernized society has already seen this, but in India we are starting to see this very, very frequently. So treatment, as we all know, maybe lifestyle changes, medications, hormone therapy. If the family is completed, they can go in for testosterone treatment, etc. And counseling is the most important thing. So I've already talked about the lifestyle changes and medication. So the main thing will be counseling, where they have to address stress, anxiety, depression, relationship issues. We see so many couples who have at least 10 to 15 years has passed by. Still, the couple don't understand the importance of as I mentioned, not only the penetrative sex, the non-penetrative sex, and spending time between the partners, all those things they still don't know. So that is where the role of a psychologist, a counselor, all those people come, and it's not a single doctor effort, it is now becoming a team effort. So we see infertility issues, all these things they come up in midlife. We even see patients who have, like, the main thing is low sperm count, azoospermia, all the sexual dysfunction which we discussed. And one more thing is oncosexology, which I will be discussing. These are all the new things which we are seeing. So men's health issues can revolve around appearance, misconceptions, reduced confidence as they age, anxiety, stress, doubts about their own selves, and mental health issues, which is now on the peak. Similarly, issues unique to men are concerns about their satisfaction, partner satisfaction. We typically see a male in the middle life coming and telling that his penis is short, it is every day it is shrinking, there is no morning erection, post ejaculatory pain, discomfort, getting anxiety about their own erections, and confidence about giving the getting the good erection during sex, and semen leak and tiredness. So these are the common issues which are and specific issues to men, which we say day in and day out in our OPDs. And coping up with midlife is to stay healthy, connecting with people. So men have stopped connecting with their friends or connecting with their doctors. They don't go for men's health checkups. So this is how they even disconnect themselves even from their partner, thinking that what my partner will think, what my wife will feel if I don't have a good erection, what if I don't have a good ejaculation, what if I'm not able to satisfy. This is the circle within which the man is, and he doesn't even go and open up to his partner. Similarly, to focus on strength setting goals and not to be afraid of the aging. So these are the things which we discuss with the men. So the andrological treatments revolve around complete evaluation, optimizing medical management, and what is beyond medical management. As Dr. Meera Madam also rightly said, these are the new services which are now being offered to men as a part of the andrological services like a penile processes, micro TC, which give a new ray of hope in these patients where medical treatment doesn't work. So we have surgical sperm retrieval where testicular sperm extraction or epidermal sperm aspiration, testicular sperm aspiration can help in infertile couples. We see a lot of men who come with a difficulty in sample collection, especially when the male is around 40, if they have unconsummated marriage, if it is a diabetic, there is even a difficulty in getting a sample. And there are some situations where we resort for even IVF in men who are not able to just give a sample. So these are the various situations where an andrologist can come in and try his counseling, reassurance, medical therapy, and other methodologies like penile vibrator, etc., which may in some patients work, and we can overcome the situation for an IVF or even help an IVF with these samples. Similarly, we have the micro TC, which is the most advanced procedure for azoospermia today, where men who have had children in the previous marriage, but they come late and they come with the azoospermia with the testicular failure. And those are the patients where these procedures can uh, give success and they can again father their own biological child. Going on to male sexual dysfunction, we identify the cause, severity, we prognosticate the condition and formulate a treatment plan. We have an algorithm where we do something called an office erection assessment along with taking the routine history and examination. We do an office sildenafil test where we give a tablet to the patient, assess the response, and if the response is not good, we do an intracavernosal injection test, which all these things help us in identifying what is the severity of the problem. So when a couple walks into our OPD with 10 years of unconsummated marriage at 42 years, so at that time, we cannot again tell that, go try this medicine and come back after a month. So it doesn't work like that. At that situation, if the wife is young or if the wife has poor aggressive, then we have to go to multiple treatment options at the same time. We tell them that fertility can be managed separately. Your erectile dysfunction can be managed to a great extent with all these newer things. And we have even gone to the extent of placing a penile processes in young as well as old couples where they have not had children, and with a good sperm they have conceived naturally. So that is the level at which the andrological care is improving. And we see a lot of men who come with the arteriogenic erectile dysfunction at say even 35 to 40 years. So that is the new new increase in these problems, maybe because of lifestyle diseases, diabetes, or early aging. So that is what we are seeing. We also teach them self injections where it is like insulin, patients can use self-intracavernosal injections when they respond to the drug, and it is like a bridge between medical and surgical therapy. We also understand that erectile dysfunction is a harbinger of heart disease. So we do cardiac evaluation in most patients who are having especially arteriogenic erectile dysfunction, where they don't respond to medications, or the intracavernosal injection test or a pineal Doppler shows loss of blood flow. We also consider this ED, arteriogenic ED, especially as a cardiac symptom equivalent. So we also assess whether they have angina, have difficulty in climbing 2 flights of stairs in 10 seconds. We ask for a TMT, we take a cardiologist consultation, and we have even picked up patients who have double vessel disease, triple vessel disease, who go in for angioplasties or CABGs, and they come back to us for pineal implant surgery. So that is again one more advantage. And metabolic syndrome is on the rise. Diabetes, testosterone deficiency, infertility, ED, they all go hand in hand. So that is the situation where we give low dose daily PDE5 inhibitors and SOS PDE5 inhibitors for erection. And this is also a therapy where the cavernous or smooth muscle can improve with these medications. And as I mentioned already about unconsummate marriage, we have had enough discussion about it. Going on to the options of medical therapy for erectile dysfunction mainly, it is maximal medical therapy, which is a combination PDE5, or a therapeutic intracavernosal injection, which I just mentioned, or a pineal processes. There is also a role for regenerative medicine, which is coming up in a big way, yet it is experimental today. We may see the inclusion of these things in the guidelines maybe in the next 5 to 10 years. The indications for pineal implants include patients who don't respond, or those who don't want to take pharmacotherapy, or those who are having side effects with the pharmacotherapy, and also organic conditions where there is a Peyronie's disease or a diabetes mellitus. These are the men who are more like they will benefit or require an pineal implant. So the types of pineal implant are malleable and inflatable processes. So even now we are going in for a lot of these procedures where men seek definitive solutions, and we have an array of malleable implants which are available in Indian market today. We have at least 5-6 models of malleable and the inflatable implants. So this is just to give an idea as to how the pineal implants work. These are all the malleable implants. So this is the Indian implant, and these are all the foreign implants. Similarly, we have the inflatable implant where we have a 3-piece and a 2-piece. So the 3-piece implant is supposed to be the most sophisticated implant, where there is a reservoir, there is a cylinder, and there is a scrotal pump. So as the patient presses the pump, an erection happens, and that is where the patient is able to have a good erection. So this is the 2 inflatable implants which are presently used commonly. So where the patient is able to have a normal looking penis other times and can get an erection when he requires it. So as an andrologist, we evaluate ED more effectively. We use the erection hardness score, which is a tool which the patient or the attender can press it and see how much is the erection. We usually ask the wife whether the erection which is told by the husband is correct assessment, and invariably the wife says that the erection is like what the husband feels, the wife feels that it is poorer. And many times we also see men coming and telling that I have come for erectile dysfunction treatment, which my wife doesn't know. So we again tell the patients that the wife usually knows the erectile dysfunction even before the husband knows it. So we do the office internal test and the intracavernosal injection test to diagnose and prognosticate cardiac assessment, and then further treatment options in the form of implant whenever required. So regenerative therapies, as I told, is now coming up in a big way, where there is a role, at least in mild to moderate ED, maybe these therapies work. Ejaculatory dysfunction again usually is premature ejaculation, but there are some men who come with delayed ejaculation or absent ejaculation. This may be primary or secondary. Like initially in the married life, ejaculation was there, but later again it doesn't happen. These patients may have stress, sometimes undergo urological procedures like TURP, etc., because of which this happens. Maybe hormonal conditions like prolactinoma, testosterone deficiency, or just simple stress and anxiety or ED, which can cause these things. Again, we go into all these discussions and identify the cause and treat these patients. Peyronie's disease again becoming very common today because of the diabetes rise, where there is a plaque in the tunica albuginea, which can lead to curvature, pain, or erectile dysfunction, where we again have something called interrelational therapy. We have surgeries to correct the curvature, or a penile implant is an option where there is erectile dysfunction because of the Peyronie's disease. Chronic testis pain again is an important condition which is often mislooked, or patients don't know that there is a treatment which exists. So most of these people may be fitting into prostatitis, where men stay away from their family. Men do not have routine intercourse because of ED or because of situational problems, or they don't have a good place for continuing their sexual life because of multiple people in the family, all those things. So in these patients, we do the prostatic massage culture, we do medical therapy, and most of the patients respond. When there is a chronic arcalgia, then we have medical therapy or a cord block and ablation, or we can do what is called as the microsurgical denervation, where we do a microsurgical procedure with the help of an operating microscope. To men who have had a good response on the diagnostic spermatic cord block, we can do a microsurgical denervation, and patients have good response of up to 90 to 95% pain relief if they had a good response on the spermatic cord block. And we see these men doing wonderfully well after this surgery. Oncosexuality again, with the sad rise of cancers in young men. So there may be some people who are infertile at 40 years, or they have not planned their family. They will benefit with the sperm preservation and the testicular sperm aspiration, etc. And oncosexuality is a condition with the improvement in cancer care. We see a lot of patients with bladder and prostate cancer because we work very, very closely with the uro-oncology unit headed by our Dr. Raghavan sir. So here we see a lot of men who come with the prostate and bladder cancers and colorectal cancers, because again, we have a very busy colorectal unit in Apollo. So these patients have fully their colorectal cancer or prostate cancer has been fully taken care, and they are now almost cured from the condition. So these patients now require what is called as penile rehabilitation, where we start the patients on vacuum erection pumps or even traction therapies, where the penile length is being maintained. We give them daily PDF inhibitors. And once the patients have completed their treatment, we can go up to the extent of placing a penile prosthesis where they get back their erectile dysfunction is completely cured, and the partners are also happy about it. So the components of men's health care include not only urological care. We have to give nutrition counseling, physiotherapy, where we teach the importance of exercises and specific exercises to improve the erection and ejaculation, and lifestyle, and also other specialties like cardiology, etc. also come to the picture. The flag signs, we educate our patients about ED being a marker of heart disease. And as I told, wellness tips, exercise, etc. all are being inculcated into the men's health practice. So there are so many things to be done even now as an andrologist, because this is all new things which we are seeing, and there is going to be a lot of requirement of these things in the future. And I thank you for a patient listening.
Thank you, sir, for such an elaborate about the male dysfunction as well as the treatment for all these things. We go to the any doubt?
Ma'am, we have a few questions in the
Yes.
question box.
Yes.
Can we just take them now? So one is, can a gynec prescribe for male partners if wife brings the husband for erectile dysfunction or premature ejaculation? If yes, how should we go about it?
So many a time a gynecologist or infertility expert usually is the first person to encounter erectile dysfunction or premature ejaculation. We can safely prescribe if the patient is not a diabetic, no heart disease, and no dyspnea, etc. All these cardiac symptoms are not there. We can safely prescribe PDF inhibitor, at least the SOS PDF inhibitor like sildenafil or avanafil. Similarly, if these patients, if they are on drugs, especially we should ask for nitrates. If there is no nitrates, then we can safely prescribe sildenafil 50 mg 1 hour before sex. Or we can even start a low dose tadalafil of 5 mg every day and then refer the patient to an andrologist or a urologist if there is no good improvement. Lot of times we see a physical examination problem like phimosis curvature, which actually leads to referral. Otherwise, many men who have psychogenic ED can respond to these medications.
So I think follow up on that, sir. How is low dose tadalafil given? And what precautions should we take when we are prescribing sildenafil, tadalafil, or dapagliflozin?
Yeah. Naproxen is mainly for premature ejaculation, and tadalafil is for erectile dysfunction. That is the major difference. A patient who comes and says premature ejaculation may be actually having erectile dysfunction. So that distinction is again important. And we can give up to a dose of 5 mg every day tadalafil, and we can add up to 50 mg sildenafil safely if a patient, as I told the previous criteria, that there are no major comorbids, no anginal symptoms or palpitation, etc., and not on nitrates.
And how is office sildenafil test done? So that is another question.
So we give the medication and we ask the patient to self-stimulate, and we assess the erection in the patient stimulates in private, and then once the patient is ready, we go and physically assess the erection, and we have the erection hardness scale tool where we correlate the erection and we give the grade as 1 to 4. That is how the OST is done, office sildenafil test.
And what exercises would you recommend for erectile dysfunction and premature ejaculation?
So for premature ejaculation, we give mainly the Kegel exercise, but the exercises for erectile dysfunction may be a core strengthening, ab strengthening exercises, which also gives benefit for the premature ejaculation.
Thank you, sir. So I think we're done with all the questions. Can we move
Shall we
on
go to
the
the next topic? Next topic is about the interventions for the female sexual dysfunction. After seeing all these causes, Dr. Sanjay Pandey is going to talk about it. He is the andrology and rheumatology urology in Kottayam. I'm not able to read properly. Can you read, Bharani?
No, he's head andrology and reconstructive urology, Kokilaben Dhirubhai Ambani Hospital, Mumbai.
Okay, sorry for that.
TV is there.
And he's a consultant in robotic urology and gender reassessment in sorry, this is not clear for me. Shanti Madam, continue introducing me.
He's head andrology and reconstructive urology since 2009, consultant robotic urology and gender reassignment surgery, Kokilaben Dhirubhai Ambani Hospital, Mumbai. Underwent advanced training in Italy for urethroplasty, Germany genitoplasty, Belgrade gender reassignment surgery and robotic surgery in Korea. His interests are in botulinum toxin, in urology, Peyronie's disease, MRKS syndrome, prosthetics, incontinent, and ICBPS. Multidisciplinary clinics at KDAH, Gender Dysphoria Clinic, Nocturia, Enuresis Clinic, and ICBPS Clinic. Welcome you, sir.
Good evening, everybody. Vanakkam to all of you in Chennai Menopause Society.
Vanakkam, sir.
Thank you so much for this invitation. I have just joined approximately 1 minute ago. My apologies on this. It's just a little situation which I have been caught upon at the hospital, and therefore I could not attend the first wonderful part of the discussions on the two important topics that we discussed. Could somebody allow me screen sharing, please? So good evening, everybody from Chennai Menopause Society. I take this opportunity to thank the entire team, the chairpersons, the president, secretary, and all those who have joined today. Few of you I may have met in my days at Ramachandra Medical College when I was an associate professor from 2000 to 2008, before I shifted to the Kokilaben Hospital. I did look at this topic with a lot of passion, because I started the work on this subject on painful female sexual disorders interventions when I was in Ramachandra Medical College Hospital. And therefore, Chennai happens to be the very epitome from where we looked at a lot of pain in the pelvis and combining together with our gynecologist in various aspects of urogynecology. Today, when I sit across on this platform, which is Chennai Menopause Society, it gives a great feeling, because many of you actually deal with all aspects of gynecology, urogynecology. But a factor which may be missed out, which we may not discuss regularly, keeping timelines intact, is that women may not always complain of sexual health at that point in time around the menopause. Many a times, many of them may have given it up for multiple reasons around. But we're looking at the large picture of women going through this suffering of painful sexual disorders. I take this opportunity also to thank you on this very important day, which feels good to be there with you, carrying greetings from Kokilaben Hospital, where I serve as consultant neurologist for the last 15 years since I left Chennai. And my deep passion today is to talk on this painful sexual disorder, of which I've been a part of since I started doing this subject approximately 17 years ago. Yes. So that's a time we never knew what was the dose of a medication which was already available. And there was not much available on painful sexual disorders, namely the dyspareunia, the refractory vaginismus component, which gynecologists do see. And many of you now in South India treat. I've been to Chennai, Trichy, Ernakulam, and discussed this with various societies around. And let's take it forward, because India and women are shining today, leading from all the fronts. So why they should be living with a lot of agony in their own pelvis? And when we have got gynecologists and menopause society, which can take it forward. But let's not forget that we also hugely governed by Hippocratic oath and looked at evidence, evidence, evidence. So the experience that we have in this subject of evolution, we got to take it forward to the next level and bring about that change in women in that age group when they're already undergoing a change. The change is about their menstrual periods changing, their pelvic health changing. In that, there can be many reasons that she could get a pelvic pain, of which one pelvic pain, which is a female sexual dysfunction pelvic pain, is a refractory vaginismus. So the goalposts have changed dramatically since we got into the subject. I personally got into the subject, and I'll give you an idea about what does it mean. So man, medicine's machine and motivation to bring about an intervention, which is an innovation called the innovation. So we get into this and look at my own journey on this 17 years ago when I was at the Kokilabin Dhirubhai Ambani Hospital. It was thinking out of the box when, at Chennai, when we looked at thinking out of the box for women who had painful sexual disorders in the midlife. A midlife crisis when they have got the discomfort, pain at coitus, which could either be a refractory vaginismus of a primary kind never performed, or secondary vaginismus with a lot of multiple changes happening in the pelvic floor, the pivococcygeus, and the entire aspect of work. We know that botulinum toxin as a drug which actually can bring about relaxation of the muscles by working at the cholinergic nerve receptors have been in urology since 2011. We use it for this indication very commonly, and urogynecologists look at this, looking at refractory overactive bladder, and probably give botulinum toxin into the entire bladder, the mobile part of the bladder, and the bladder becomes a semi-paralyzed one compared to the refractory overactive. It's brought into a sanity from where the contractions go down. So we take that cue from 2011 FDA approval and look at that. The sanity of the bladder is brought about by this refractory overactivity, only by an injection called botulinum toxin, where in the detrusor muscle, it works anything between 6 to 9 months. And now with some innovations, we have seen that it worked till 9 to 12 months also. So let's take the cue from here and identify what does it happen around. So we inject into the bladder wall. And when we do that in the bladder wall, we bring about a sanity of this excessive bladder contractions. Now we're looking at refractory vaginismus as a picture, and we're coming to this timelines. Now, 2011 is when the urology got approval for this molecule. And this has been used for multiple reasons, for multiple indication, because it's a drug whose effect gradually gets reversed. So in cosmetology, in neurology, in physiatry, in urology and urogynecology, this drug stands very tall right now with the situation. But when you look at female sexual dysfunction, when we look at women requiring treatment on that, leaving alone the hypoactive sexual desire disorder and the kind of couple phenomena which the first two speakers did talk about, I'm looking deep into a situation which is an agony, which is a pain, which is a kind of a dilemma that she lives in. That dilemma is very difficult for us to define, because many a times a woman may not in a prime of life go and tell a respected gynecologist in Chennai Menopause Society that I am going through this situation of pelvic pain when I have a coitus, which was perhaps there or has worsened or is a new onset kind of a situation, a deep dyspareunia or vaginismus. We also know that chronic pelvic pain syndrome, which can bring about a crosstalk and various activities in the pelvis, which brings about that kind of a discomfort, to which many other syndromes have been ascribed to, can also bring about a discomfort during the sexual activity. But when I look into female sexual dysfunction, I look into one subset of that. Refractory vaginismus is very close to me, because over the 79 patients which we did inject till 3 years ago, the data was, we have injected 17 more. Many of them were doctors and doctors' wives. Why do I say so? Because they had no place to go and go through it. So age groups of 25 to 55, we looked at women who went through this situation of please help me. That means I wake up thinking about my condition and I go to sleep thinking about my condition. I think it 1,000 times a day because I go through that discomfort and pain. And this has been there for quite some time. So I'm looking at as young as 24 years young, or it could be 55 to 60 years young, could be a primary or could be a secondary refractory vaginismus. So in the age group, when we pick up more numbers of the reason for infertility or for the reasons of female sexual dysfunction, we know the marriages can go unconsummated. And many a times it could be a male who could be labeled as possibly the cause, but not necessarily. An involuntary and very uncontrolled fear. The fear is more psychosomatic. But clinically down there's a failure of a pain-free coitus because this lady doesn't allow our respected gynecologist even to examine, even to touch, feel, and even to be examined by on her own kind of thing. So a gynecological examination many a times can be difficult because it is that involuntary refractory contractions of the pelvic, perineal, pubic muscles around which go into a massive kind of a contraction. It's believed that the primary refractory vaginismus is more of a habitat disorder, more of a formative disorder, more of a milestone disorder. But when it comes to as a secondary vaginismus, which could happen maybe because of atrophy of the vagina, but that may not be the cause. It's because of the spasm that goes through in the muscles which surround the vagina. And the vaginal muscles are stronger than many more muscles in the body because we know the vaginal muscles are capable enough to expel a baby. And look at the kind of vaginal contractions which can go through when it is refractory. My work on this subject goes on till 2005 when I met Dr. Pasek. We were looking at a joint work and I was a part of the US FDA approval team looking at treating this very important aspect of getting women pain-free. We looked at this aspect and worked on this where I contributed 27 cases back in Chennai to this important world trial, which was done by US FDA on botulism toxin injection for treatment of refractory vaginismus. Total of 376 cases, of which Dr. Pasek has close to 264. The rest came from Israel, Indonesia, and Canada, and I was a contributor of 26 cases around. So when we look at this large picture of women going through painful sexual disorder and getting well, it is all about looking at the awareness, awareness, and awareness. And I'm sure more than that, awareness in our own cross fraternities between urology, between gynecology, between geriatricians, and between people who work on the pelvic health may also be missing to quite a level because people may have been guilty of doing an episiotomy, stretch dilatations under anesthesia. None of them actually worked. Many of them were labeled as psychotics and probably the pain is not there because there's no disease per se and they have been actually gone to psychiatrists. The poor husband and probably the poor couple have suffered till we knew the actual pathophysiology and moved it forward. That's in Hindi and that's not for us, but these were the campaigns which I did when I came to Mumbai after the groundwork in this subject, where I was working a lot on the neurogenic bladder and on the overactive bladder on the same disease. And I must tell you that in the bladder that it works for 6 to 9 to even 12 months, in the skeletal muscle, which includes also the vaginal pubic muscles around and the skeletal muscles, it does not work beyond 4 to 5 months. On average, it only works for 3 to 4 months when you inject it into any kind of a skeletal muscle. So the revolutionary treatment which could bring about a change in the cascade of a woman going through this aspect of painful sexual disorder can actually be broken as a vicious cycle by giving this drug, which brings about a change in the entire cholinergic nerve receptors at the level of the skeletal muscles, at the level of any muscles where we are injecting in. And your physiatry colleagues and neurology colleagues can inject a lot for issues of muscle spasms. So taking that into question, let's look into one lady and then we can take questions around. 29 years old female, married for last 5 years, had failed all attempts towards sexual intercourse. If she fails, she could probably be landing up later in menopause also and could present to menopause society. But as cause was refractory vaginismus, causing huge distress to the couple, who were otherwise very thoroughly emotionally bonded. So they were a bonded couple. They lived in the heart of Chennai in Mylapore, and they are the ones who attempted everything with our colleagues in urology, gynecology, psychiatry, yoga, everything what was possible around. She was given a lot of chance. But the clinical examination when I did this showed a satisfactory vaginal capacity to a finger examination, albeit she had gross vaginal contractions. The contractions are massive. She was very uncomfortable otherwise, which is labeled as a Lamont's classification of Lamont 4. So Lamont was the one who actually classified vaginismus into type 1, 2, 3, 4. We don't discuss 5 because 5 becomes a psychosomatic disease completely. So 4 happens to be a very refractory kind of situation where a gynecologist examination Doesn't happen. Now, this is different from what we call as vulvodynia and vestibulitis, which is different. This is completely deep, innate muscle contractions where the own vaginal examination is completely uncomfortable. So when you look at that and we look at an index case at any age group, it is all about a lot of counseling because one is not comfortable about her own body at any age group. And when that happens around, we need to discuss about a possibility of a supervised self-calibration with vaginal dilators, which is what our gynecology colleagues across the world do. Many a times they will be very comfortable with the partner and a partner participation is sought for. And a huge amount of psychosexual counseling, which is best done by gynecologists, not by a psychiatrist and a clinical psychologist. Therefore, we need to spend time sometimes in between the busy schedules that we run around, looking at all the aspects around. But we know that she is a refractory vaginismus and she's going through the distress. So kind of an attempt to practice, an attempt to probably take it forward would happen when these kind of women come with refractory vaginismus, where they agree to get these muscles silent. The muscles are contracting erratically. She has seen, her gynecologist has seen her, our finger examination show that she's Lamont 3 and Lamont 4 kind of a situation. So the management is always under general anesthesia. In fact, in the last 3-5 years, we have not examined any woman beyond just discussion because we have already been referred by gynecologists in the city of Mumbai and this part of the world. We don't examine them in the outpatient department because they're too distressed already. The examination is completely under general anesthesia with an understanding that we'll take it forward as required. As I said, many of these women have a roomy vagina and a finger can go or two fingers can go under anesthesia. There are two kinds of subset of patients whom we see. One set of patients who did tell from the history and from the clinical examination and from the referrals from our gynecology colleagues that there is that innate indigenous kind of a contraction, but doesn't allow this escape of contraction even after a psychosexual counseling, partner participation, giving her a freedom and a relaxation. These patients do very well with a 200 units of injection into the periphery of the vagina, not the vaginal mucosa, but the vaginal muscles. Those pubococcygeus muscles, which actually are the outer half of the vagina, which is the sensate part of the vagina, is actually injected. I'll show you some pictures to take it forward. Once we do that under anesthesia, which is 5, 7, 10 minutes, we look at a progressive lubricated vaginal dilator to be kept out there. So there is a set of those plastic vaginal dilators which are available from 0 to 4, which I use for female vaginoplasty in my gender reassignment surgery work. We put the largest dilator which can just walk in very easy because this is a normal, capable vagina with room allowed and the vagina itself can dilate. It is all about that kind of a habitus where the muscles are not relaxing with anything. We look at the mucosal bupivacaine injection, which is injected along the mucosa of the vagina, which gives her the discomfort level going down gradually when she comes out of anesthesia. And then we leave the largest vaginal dilator in place, which she cannot imagine as she gets up and says, how did this go inside? I never could have done that. So the dilator stays for an hour, 2 hours, or 6 hours as required. The dilator is removed by her or sometimes by her partner. And thereafter, the whole process of mitigation starts around. Normally, this entire aspect of treatment can be done in daycare, but I have kept everybody overnight and discharged the next day early in the morning. When we look at this aspect, we also know that there has to be a process beyond this. And the process beyond this is about we need to look at how to take it forward because this is an injection. It will act on the muscles. We've injected it all around. We could use a smaller needle if it is a smaller one, but I normally now use a spinal needle to be able to reach the entire outer half of the vagina deep in the muscles and come back. So the injection of 100 units has been given to some patients, but I have looked at 200 units because we cannot go back a second time. The reasons I tell this is there's only one patient who failed, and that's why I come to the situation now that post-procedure therapy. So when we have given botulinum toxin in the vagina, and the vagina, as I said, has gone back into its sanity of contractions compared to the erratic contractions, we are safe enough. In other words, I have actually paralyzed the vagina for a short while. In doing so, and giving a bupivacaine locally, she's comfortable immediate post-operatively, which is more important. She goes home. The time taken by this molecule called botulinum toxin to work is anything between close to 12 days to 16 days when the activity actually starts. I know that 3 weeks is a good time when the peak is actually starting to happen. That's the time we normally invite the patients in 2 to 3 weeks to look at the partner and them coming and discussing the prospects around. Those prospects are about supervised calibration with the smallest dilator, telling her how to do it and probably asking her to do it. And when she touches and feels she finds that spasm is gone because the vagina is actually not contracting erratically as a amount for vaginismus that she had. And that actually does wonders to a lot of patients. I come here to tell you that there were 3 patients in the 79 patients that we actually looked into and compiled who did not get result, and the reasons were very clear. That means they got an effect internally, but 2 of them had their husbands as marine engineers, as sailors, and one person whose husband has probably left immediately after the activity. Now, what happened is, if there is no supervised dilatation and calibration, you're not able to break both the somatic component and the psychotic component of this whole thing. The drug will be effective only for 3, 4, 5 months and not beyond that. The lady came back and said, my husband had gone for 6 months and we could not come back after the injection, but we were very happy that there was no pain, no discomfort in the initial days. The effect of the muscle is gone. Effect of the injection is gone into the muscle. And when they attempt looking at that, the magic would have happened because Dr. Pandey or somebody injected, it does not happen anymore. She got 100 units injection as a redo injection. Now that she's psychosomatically clear that my initial days of my touch and feel and my calibrations were good, but we did not get into an activity because practice makes a man perfect or a woman perfect. The practice was not done. So that many of these patients now understand that they have to break the vicious cycle in the first 4 months. The first 4 months are very important after the first 2 to 3 weeks where the effect of this molecule is dramatic. So it's the way forward is when we look at, I've just cut the video into pieces around to look at the examination and anesthesia where she's under general anesthesia. And we look at the outer half of the vagina, feeling the pubococcygeus. Let's not forget, many of our gynecology colleagues in the audience also are wonderfully in examining the myofibrous bands and the kind of bands which look into. They could be a secondary cause of vaginismus in many women, causing a secondary vaginismus. That means there is a spasm of the vagina and a gynecologist picks up those myofibrous bands around, which actually can be injected even with local anesthesia to break the vicious cycle. These myofibrous bands are best worked on when we inject botulinum toxin, where the activity starts in 2 to 3 weeks and probably goes on for 4 to 6 weeks. So secondary vaginismus more will not be like a refractory primary vaginismus, where the vaginismus is all related to a disorder of the muscles, activity, incapability, habitus, confidence, never performed before, compared to somebody who develops his myofibrous bands in the prime of life, developing secondary vaginismus. Could also be chronic pelvic floor contractions and the pelvic floor dysfunction, which again would work best with botulinum toxin. And therefore, when we look into that kind of spread required, then the spread could probably be 200 units and not 100 units alone. It is normally diluted with 20 ml of normal saline, preservative-free normal saline, and injected all around. So the injections are after this examination and feeling. Now, once I use a spinal needle, I go all the way lateral on both sides from the level of the introitus deep along the muscle plane and inject it deep on the muscles. We're looking at the muscle activity being paralyzed as a result of this injection, which I said will take its own sweet time. I need to tell you that this is so important that the injections have to be in that framework, the lateral component only. Way back in Chennai, when I started these injections at that point in time, my first 2 injections were in St. Thomas Hospital. I remember the story of these 2 women who actually were failing their marriage, and they were patients to me at the Ramachandra Hospital. When I injected the first 2 cases, because there was no dose available at that point in time, 17 years ago, where we worked on the dose finding study with the FDA and PASIC study, I sadly injected even anteriorly and posteriorly. I never knew it. That's how a confession is 17 years ago. And when I injected anteriorly, laterally, and posteriorly, these women got the injection. They went home the next day morning. This was injected in the evening. And around 2 weeks later, they came back with 2 important disasters. One was a urinary incontinence. One was a fecal incontinence. So what does it mean? I had injected it along the sphincter of the urethra, injected along the sphincter of the rectum, and injected 300 units because that is the time we were injected 300. 200 was never known. So because that was the dose for the refractory neurogenic overactive bladders before the dose finding study came. So for the first 2 weeks, they were fine. 2 weeks onwards till 2.5 to 3 months, they had urinary and fecal incontinence. I knew this would probably go away. But till that time, I was running away from them because I had given them a gift, which was sadly a result of an injection that actually can bring about that. I also knew that I was waiting for this to get cleared up so that their diapers goes away, because they would then be capable enough because the vagina was also paralyzed. And it actually happened. It actually worked in our favor. Once they came up back and said, my diapers are gone, Dr. Pandey, what next? We understood that the anterior posterior injections were wrong on my part. And therefore, For the next 76 cases, of which 33 were in Chennai, 26 contributed to the USFDA, and the rest 40 out here in the last 15 years, we injected only laterally. So the lateral deep injections are the ones which we prophesize. We looked at that injections. We give bupivacaine on the mucosal aspect. We leave the largest dilator. The woman goes home. She's told that the largest dilator can walk in very easily, but we'll start with the smallest dilator and go gradually up the ladder with her, with the partner, 2 weeks plus on the third or fourth week. That's how this entire process works. So once this is, as I said, minimal anterior and posterior now, but we don't inject anything anterior and posterior. The largest dilator goes into the place. And there is this important confidence building approach that comes up when the dilator is brought about by her saying that we never could put a dilator, Dr. Pandey. How did this happen? So imagine what urogynecology can be in absence of a teamwork between a woman, medicines, motivation, because if we always do what we always did, we'll always get what we always got. In other words, women would continue to live in pain and we would give them all kinds of medicines which could work on the neuralgia component of it, but we'll never take it forward. So journey of 1,000 miles for many gynecologists in the country who came and saw the demonstrations here. And when I spoke in few gynecology societies on the videos, which I'm not able to present today, only a commitment could have been a game changer at that point in time on a subject, because I practice a little bit of urogynecology on the incontinence aspect. So journey of 1,000 miles started 17 years ago and feels proud of those women. Unfortunately, many of them were actually doctors and doctors' relatives. That's how the whole picture had started. So when I look into the large picture, I understand we live in an era of stress, innovations, industry, technology, competitions, but also in the era of evidence-based medicine. Also in the era of enormity of disease and data, because this is just not an unknown phenomenon. It's a huge phenomenon for women that they go through it. Setting standards of very high order would only take it forward to the highest level. Giving them a spoon of rice would not work. They would probably require a bowl of rice. And therefore, interventions where we could be masters to take it forward to the next level could be the innovation or the innovation that I was talking about. So as I come to a close on this topic, I wanted to take any questions on this, because refractory vaginismus, refractory painful vaginismus acquired in the prime of life, where a woman comes and sees Chennai Menopause Society esteemed colleagues, or women who go through this disorder as a part of their lifestyle phenomena where they fail consummation, can be treated and cured. When we look at this injection, there was an era when women have done episiotomies, where women have got dilators, and things have happened under anesthesia. I'm sure we are aware of that. But taking into consideration this aspect and not holding it any longer, this is a subject which could be taken forward to very high levels for women who treat women, and all of you are an esteemed audience who do it very well. Thank you so much. If there are any questions, I would love to take. My apologies on not being able to show a video, but maybe sometime when I come live to Chennai, I would do that for you.
What is the cost, and what is the any other side effects you experienced?
So wonderful. The cost for a 100-unit vial in today's world is anything between 18 to 23,000 rupees, because there are few brands of botulinum toxin available compared to the originator called the Botox. So there are Indian brands also available called the Ciax, which is used by gynecologists and cosmetologists. And there are few brands in India available which are equally effective. I have used them. So the cost of 100 units costs anything between 18 to 23,000 rupees. My understanding is that 100 units is not the greatest of the dose in a refractory condition of this kind. I've not done 100 units for a patient now in the last 3 years as a primary injection. I said I had a 3 patients who required a secondary injection, but they'd already crossed the bridge where they did not require to be facilitated on a lot of psychosomatic counseling. So there the injection could work as 100 units. The side effects are almost nil right now, because though it could be the most effective poison ever made in the world, it also has been downgraded or attenuated to a level where no major side effects. You obviously cannot inject into a vascular system, and that's why whenever you inject anything around, you suck and look at you're not into the artery, which you cannot be in that area, because you're absolutely on the muscle wall. You don't have to be digging your small needle deep, and therefore you can be far away. The spinal needle number 22, 24, all works very good. And you are laterally and tangentially moving along the lateral vaginal walls on both sides. So I've not seen a side effect yet. It was told in that era when we used to inject the 300 units in the bladder that some people looked at a little bit of weakness on the first day. But I confess I've not seen a side effect of any of them. The side effects were on those who did not come back on a follow-up, who probably would not follow the regimen beyond the procedure, where we need to get into 2 weeks plus into an activity where we take it forward. Otherwise, I don't think there's anything to do.
Thank you so much, sir. Talking about your experience as well as about the injection, how it should be done, and where to place the injection. Everything was in so detail. Thank you so much, sir.
Thank you very much. Thank you, everybody, for this
So I think
opportunity.
we also have one question from the chat box. Somebody who wanted to know if there are at what points in vagina do we give the injection botulinum toxin, and what precautions? I think you've explained, sir, and any specific reference to time clock positions for beginners. That's what the question.
Wonderful. Awesome. So the most effective would be in primary refractory vaginismus, where you as a gynecologist have seen this subject. More so, fertility experts look at more of these patients compared to the pure club of gynecologists and obstetricians, because they look into the fertility aspect and understand that the marriage is still not consummated with no male factor issue, which Dr. Karthikeyan did talk about. So looking at the aspect of timelines around, the waiting time only adds more and more agony. So a patient comes to you, look at consent and inject around. The earlier we inject, it is better for them, because we know that this medicine acts in all the muscles. It just depends on when and how we need to inject in whom around. The other question was regarding the cost, is it?
No, clock positions. If
Okay, yes, thanks. Okay. Now also the injection part. Sorry, I missed out that. So the vagina musculature is best felt upon when you actually examine women every day and you feel the lateral part of it. You can find that there is a muscle contracting. Ask the woman to contract and she would actually tighten up your fingers around. The anterior and posterior are things to be avoided. From my very experience and confession, that you would actually give injections into the aspects which are not to be treaded around, the rectal and the urinary sphincter. So that is the lateral aspect which I showed to you, starting from the upper part to the lower part. That means you start from 1 o'clock and go down to the 5 o'clock, and you start from around 11 o'clock and go down to the 7 o'clock. So when you're looking at that, your injections are tangentially placed, something which when you do your stress incontinence surgeries, your scissors are tangentially placed. So tangentially you move across. The injections are not to be given in the fornices. There's nothing required in the fornices. The entire aspect of dysfunction, discomfort, pain, contractions are in the outer half of the vagina. So outer half of the vagina will absorb 20 ml of 200 units. 100 units each could be injected on both sides. It's available as 100 units vial and 200 units vial. You can only take 6 ml into the vial to 8 ml into the vial. Remember, these vials are not to be shaken. All vials are a bit shaken. These vials are not to be shaken. They just have to be rubbed like this, because if you shake them, you convert a fluid or liquid into a gaseous fluid, and you cannot inject gas anywhere around. So no bubbles should be formed. This is a vacuum injection, of which if you look at the entire vial, you will find nothing there. Looks like that there's no injection, but it's a freeze-dried kind of an injection, which is at the floor, and you cannot see it most of the time. It's not visible. So the injection is always there. Don't call the company and say that there's no injection inside. There's no powder visible. It's a freeze-dried injection, which is fixed at the bottom. The moment you put normal saline inside, it will vacuumize and pull everything inside. So you have to control the plunger very well and let not the injection run in, because when it runs in, the entire thing will become a gas and you have to throw this off. Always the botulinum toxin vial is opened after the examination and anesthesia, looking at there are no other aspects. The best examination for a woman of this kind is done only under anesthesia. And thereafter, the injections are in the outer half of the vagina. 20 ml is a good point of an injection. Everything should be liquid. And here you don't need the long botulinum toxin needles. You need just a spinal needle. Tangentially inject on the lateral half, starting from the, as I said, 1 o'clock to 5 o'clock, 1 o'clock to and 11 o'clock to the 7 o'clock kind of position. Once you've done that, inject bupivacaine into the mucosal aspect and raise the bleb on the vagina so that she gets up, not in pain. Your dilator goes inside, and that's a great confidence building approach. Not that you want to put a dilator for any reason, but building up a confidence in a situation where there's lots somatic and a huge amount of psychosomatic. So that's how it works. None of you will fail when you do it. For a beginner, it's going to be very easy. Just that don't let the saline run into the vial, because it's vacuumized. You control the plunger, drop by drop, the saline goes in. Once it goes in, gently just rub it for 5 minutes. After that, suck everything out and then mix with the amount of liquid. It makes it 20 ml. 20 ml is a good amount of liquid, because you want to populate the entire lateral vaginal wall thoroughly well with that amount of injection, because you don't want the patient back second time for this injection.
That was very nice from you, Dr. Pandey. Just a small clarification. Actually, your that complicated patient what you told out of interest, both the leaks, urinary and the fecal leak. How could you explain, and when that complication get waned off?
Yeah. So that is a complication which I did discuss even in the plenary talk in the USA when I did talk about this. So I did confess that we should never inject anteriorly and posteriorly when Dr. Pasik was presenting it to the US FDA. So the effect started in 2 weeks' time. 15th day, both the patients came over. One came early in the morning at 8 o'clock in distress. Other came late in the evening. One of them was a former staff of Ramachandra Medical College. Other was probably working outside in Adyar. And I knew I'd met a match. When they said that we are on diapers, urine is leaking, I have fecal incontinence, I understood I've done a mistake. But I knew that this is temporary because I know the whole effect is temporary, which is known by its effect going away. I knew that I'm not sure what, because this is all skeletal muscles. They would go away in 3-4 months' time. I said, you will have to hold on because we are looking at saving marriages, looking at consummation, and you will do awesome. So I said, hold on. So obviously that's something which you have to take cue from a public platform like this, but this is 17 years old story. I don't speak it so regularly. So this is something where you will know that anteriorly no injections, posteriorly no injections. In other words, we inject this for detrusor sphincter dyssynergia. We inject in the skeletal muscle of the sphincter where we paralyze the sphincter. I do it both for women when we get DESD, or we look it for DESD in men when we do it cystoscopic injection. Dr. Karthikeyan must be doing it. When we do that, we identify the skeletal muscle and we inject it. Difficult to inject. So don't think it'll be an easy injection going in. The skeletal muscles of the pubococcyx are very tough muscles around, even under anesthesia. You'll find it difficult. When you find it difficult, withdraw the needle by 1 millimeter and by 2 millimeters and inject yourself. Don't let an assistant inject for you if you are the primary caregiver, because you are responsible for your patient whom you have promised a wonderful result by spending 46,000 rupees for botulinum toxin. She would agree to anything, and this is a great cakewalk when she comes back in 3 weeks' time, say that I am able to calibrate. Why did you not do it earlier than this? So that's how it is.
Thank you. Thank you.
Thank you.
Thank you very much, sir. Barney, now quiz.
Quiz, yeah, we'll move on. Quick quiz for the delegates, following which we'll have the panel discussion.
Barney, ma'am, shall I start?
Yes, please start the
Okay.
quiz.
First question.
Yes, Sahiti.
Last 5 seconds. Time up. Second question. Last 5 seconds. Time up. Third question. Last 5 seconds. Time up. Fourth question. Last 5 seconds. Time up. Fifth question and last question. Last 5 seconds. Time up. Thank you.
Thank you so much. So I think we're done with the quiz and we're going to move to the panel discussion. There is a small change in the panel discussion. Our moderator for the panel is going to be Dr. Rajapriya Ayyappan. And may I also request Dr. Vidya Bandukwala to join in as a panelist for this panel discussion. I take great honor and privilege to introduce our chairperson for this panel discussion, Dr. Radha Madhavi Madam, Founder President, Tiruvannamalai OG Society, Director, Raja Multi-Specialty Hospital, Joint Secretary and EC Member TNFOG, Member of FOXI, ISAR and IMS. She's a practicing gynecologist since 1994, conducted 3 annual conference, GestoCon in 2017, 18 and 2022 at Tiruvannamalai Medical College, and her field of interest is obstetrics in rural areas. Welcome you, ma'am, and I request you to introduce our moderator and panelists.
It is with great privilege, I would like to introduce Dr. Rajapriya Ayyappan. She is the Managing Director of Om Fertility Center, Srinivas Priya Hospital, Perambur. 2023, she was position of Secretary, Indian Fertility Society, Tamil Nadu Chapter, Secretary, Women's Wing, Perambur IMA, Managing Committee Member, OXY, Endometriosis Committee Member, FOXY, Executive Member, ATN, RCOG and FPSI. There are many things which she has left out in her CV, and most of us know Rajapriya. Welcome, ma'am.
Thank you so much, ma'am. Thank you for that kind introduction. You can also introduce the panelists, ma'am.
Dr. Karthikeyan has already been introduced. I would just like to add 2 words. His talk was excellent. Dr. Karthikeyan is a microsurgical andrologist and urologist at Apollo Hospitals. He is a council member, USA Andrology Section member, Global Andrology Forum, American Center for Reproductive Medicine, editor of Men's Health Society of India, founder convener, USA Andrology Section, gold medal in MCH from Rajiv Gandhi University, Bangalore, and Dr. Siddhant Gupta Memorial Medal for Best Outgoing MBBS Graduate, Young Urologist Fellow 2019 and Fellowship 2018 ASU, Sitaram Memorial Essay winner, Davangere PG Symposium winner, and publications in indexed journal, highlighted I would guess, 88 journals and PubMed 64. He gave an excellent talk on all the aspects of male sexual dysfunction and evaluation of erectile dysfunction, surgical options such as penile prosthesis, implantation and curvature correction. Dr. Sumati Anand ma'am, she is an MD from JIPMER, DNB and CIMP. She is the consultant obstetrician and gynecologist, managing director, Raj Hospital, Madurai, completed MBBS at Madurai Medical College, pursued post-graduation at JIPMER, completed DNB in JIPMER, completed IMS certificate CIMP in 2023. She is the organizing secretary of IMS South Zone Conference, joint secretary Tapisar Madurai chapter 2024. She has a research paper on calcium supplementation in prevention of PIH, which was published in American Journal of Obs-Gynae. A voracious reader, has a lot of interest in research papers, actively participating in medical camps and awareness programs, a skilled administrator and dancer, a classical dancer, which we saw with the second TNFOG conference held at Trichy recently. Welcome, ma'am. Dr. Deepa Ganesh, advanced laparoscopic robotic and cosmetic gynecologist. She is director DG Laparoscopic and Cosmetic Gynecology Clinic and Laser Vaginal Regeneration Institute of India. She is the first Indian associate of Laser Vaginal Regeneration Institute of America. She is a fellow in cosmetic gynecology, Los Angeles, USA. Diploma in Advanced Cosmetic Plastic Gynecology, Florida, USA. She has a fellowship from International Society of Cosmetic Gynecology. She is a fellow of World Association of Lab Surgeons and International College of Robotic Surgeons, member of American Academy of Cosmetic Surgery and European Society of Aesthetic Gynecology, international and national training and teaching faculty, international and national publications and book chapters in cosmetic gynecology. She is the first certified official provider G-Shot in India, and she is the key opinion leader for lasers energy. Welcome, ma'am.
So, can I just screen share, ma'am? I thank Chennai Menopause Society for having given me this opportunity. And I think just within an hour from a panelist, you become a moderator. So that's how life is. And we as gynecologists, we have the unique privilege of dealing with women. And I guess we can't do any better than trying to sort out their problems. So I'm just going to hold the whole panel as how our regular gynecologists may encounter and how best to help them. So without further delay, we do understand that the woman has so many roles to keep handling. With relationships, she's a daughter, wife, mother, daughter-in-law, career woman, friend. And for her own self, there's hardly any time. And that's how the Indian woman's life goes. And when it comes to sex, Indian women equate sex to having a baby. So it's like maybe one baby or two babies she has. The life goes in for a retirement. And that's why we are holding the same panel that midlife is probably a time for sexual crisis. When suddenly you find the woman saying, I want a separate bedroom, I don't like having sex, I'm developing yeast infection post-coitally, I'm not enjoying sex or having orgasm, whereas my husband is, I've had a hysterectomy, so I think I don't want to have sex anymore. So these are women we encounter in day-to-day practice. So, and there's a lot of papers which see midlife sexual problems as key problem. So I would like Dr. Sumati Anand to say, like seeing she's a very versatile personality, when do you think midlife age actually begins? So what age, which age you would say this person is in midlife?
Yeah, very good evening.
Yeah.
Midlife actually starts as early from our late 30s and goes on to 40 plus, and previously which was taken as a midlife. Now I think even the perimenopausal is shifted to on to be like a midlife with too many bubbly approaches actually.
So if you ask Deepa Ganesh will say even 50 is midlife with all the cosmetic gynecology, right? So as women live longer, I think there is a shift, just like how Dr. Sumati said, it was probably in the 30s, ideally speaking, but depending on the lifespan of woman, it can be at any segment. And that's an important, say 1 to 2 decades where they really need us to go through the various problems they're having. So much of somatic changes, emotional changes, completely the bedtime story changes, who's the active partner and who's the passive partner. And anything and everything, estrogen is getting blamed. And maybe a lot of women actually find a second life. They may start pursuing a hobby and they may find that more interesting. And end of the day, that's a segment of life when they feel empowered. And living in Chennai and in most major cities, I think women are going through a changing lifestyle. Now we have to start asking women, do you smoke or do you take alcohol? And even I think that has started becoming more common in the cities. And a lot of them are on medications which can affect their sexual appetite. And we really had a beautiful talk where stress was seen as a key factor which affects sex drive. So the concerns which we are going to address in different forms of case scenarios is the quality of intimate sex relation, partner factor, whether the partner has erectile dysfunction and whether the partner has a lack of interest, and whether the woman has expressive attitude or a hesitancy to express. And we as gynecologists should not fall into the segment of medical negligence. Now, this is a 32-year-old primary para. She conceived with treatment for polycystic ovaries. She's a working woman. She had a C-section 8 months ago, and post which she was in her mother's house, which is probably the tradition of India, for almost 4 months. She stopped lactating 3 months ago. She is now with her husband for the last 4 months. However, she has not resumed her sexual life. So, Dr. Vidya.
Yeah.
So, do you think she may be having an hypoactive sexual desire disorder? How would you like to look at her problem? Why is it that she's not yet resumed her sexual life? How best do you think we can handle it?
I think yes, she's just delivered, and 8 months back stayed in the mother's house. So there has been a separation from her partner for almost 4 months. And we all know, as women are multitasking and multifaceted, she's probably also keeping awake as a mother to take care of her child's needs at the night, being a working woman in the daytime. So all these psychological components also do work. And this leads to the hypoactive, functioning. So I think it's just about her mindset changing at this point, and also because there is no practice. So sexual act is something that needs a lot of practice. So if there is a gap, then there is definitely a loss of interest, and at the same time, a tendency of having pelvic pain, the genitopelvic pain. So I think it has to be addressed completely. She needs a proper counseling at this point.
Do you think this could have been prevented?
Yes, I think whenever we have patients who come, we must always open a conversation or initiate a conversation regarding their sexual life. I think as
When would you do it?
gynecologists,
Sorry to interrupt. When would you initiate the conversation as
so
resuming
I
sexual?
think with her follow-up, all her follow-up, we always talk about her feeding, her lactation and all that. But at the same time, I think we should also bring about the sexual issues that, postpartum patients, because of the changes that she's going through, because her body image has changed, she has gained weight. So there is a loss of self-esteem at this point of time. So I think at that point, it is very important as a gynecologist to also pinpoint on the sexual issue. And I think if she is open and she is comfortable, it's very, very important to counsel her regarding the same.
Now, it's actually been quite a long time, right? I would like Dr. Sumati to take this question. So it's almost, we've lost that opportunity, no? Like when we're having the puparium review, we should have addressed it. Now she has gone into a particular factor like polycystic ovaries, the entire 10 months of pregnancy, she has not had sex. Post that also another 8 months, she has not sex. So 18 months of kind of a disuse factor. And do you think as a gynecologist, we will be very easily able to deal with it just by talking to her? Or do you think she may need medications for it or a devoted counselor?
I just feel first she should feel safe that she will not become pregnant, and the spacing, that is more important. Being a PCO and the amenorrhea, either due to PCO or due to lactation and such a long gap, they have to make her safe first. Feel herself safe that she has to have a gap, because it's just 8 months back she got a cesarean.
Absolutely. I think so. We have to understand when we talk to them in the puparium visit, that's encourage them to have early sex, address their practical issues. If she's a career woman, whether she has support to raise the baby, and whether a lot of trying would have happened, no, when scheduled sex and all this, so a lot of monotony would have happened. So we should encourage them with contraception to get back to sexual life, and above all, address the obesity and her lifestyle. No, she needs to lose weight, and her body image distortion. That's also something we spoke about. And if we're not able to break the ties, I think sometimes you find postnatally the women just abruptly say, no, doctor, we are not going to be sexually active, or we are planning to have a gap of a year or two. So even if we encourage, have you encountered such patients? Even when you encourage resume sex, they'll say, no, I prefer abstinence for another 1 or 2 years. Like it's actually like, I want to break free. I don't want to have sex. So how do you deal with those kind of women? Do you think counseling may be necessary?
Yeah, for sure. Most of our women, particularly, they just, after having a child, they just feel having sex is very secondary.
Yeah.
Though it
my
doesn't
job is
affect
over, no? Like my job is over.
Yeah.
I've given birth to the baby.
That's there. So
I think it's
counseling
all
is
about
more important. Counseling is more important, saying that sexual act is also for well-being and to make a safe sex. I think we have to counsel her and explain everything.
Yeah.
In a plate of tray, everything has to be explained.
Okay. Let's move on to the second case. I think the first case is telling us intervene on the time. As gynecologists, we have that opportunity and address it holistically. So this case, she's a 46-year-old. She's para 2. She has 2 children. And the second child is 24 years old. She's a homemaker. And she's had a total laparoscopic hysterectomy with both the ovaries removed for adenomyosis. And she's had a post-op review 6 weeks later. And she's completely recovered from the surgery. Dr. Deepa Ganesh, how would you like to address her sexual aspect of well-being?
The first thing, good evening, and I would like to thank Dr. Meera Raghavan and the Chennai Menopause Society for inviting me as a panelist. Most of the time, post-hysterectomy, especially when the ovary is also removed, obviously they're going to come with the vaginal dryness. That will be the first complaint, when they want to resume the sexual thing. So first that will be asked, and then initially we'll ask them to whether they've resumed having sexual intercourse, and most of the time they'll come and complain I'm having the vaginal dryness. That's be the first initial complaint.
So this is just 6 weeks post-op. No, she wouldn't have even resumed as yet. So it's like you're doing a post-op check whether the wound has healed well and all that. I just wanted to know when you will initiate, encourage her to get back to sexual life. So usually,
usually it takes 6 to 8 weeks for all the sutures and everything.
So you advise to resume after 8 weeks?
Probably whenever she's comfortable, but at least we give 2 months time. Whenever she's ready, and obviously they'll have some discomfort and pain, and especially when I give a gap, there'll be the first thing they'll complain of vaginal dryness.
Yeah.
So
So I think how would you also want to know how her past sexual history was? See, I'm talking about today's postnatal woman. At a younger age itself, she wants to have a break. So
you have mentioned that the quality of life is good.
Quality of life is good. I'm not talking about her sexual quality, because I think we look at
I would like to interrupt here. We are looking at a 46-year-old lady. And she's undergone bilateral oophorectomy. And we have to realize that with the sudden cessation of the estrogen, we're also looking at a decline in the androgen level because of the bilateral oophorectomy. We have to prep her up for the changes that she's going to undergo immediately in few weeks' time. So I think that is the most important part of counseling. And resuming sex, yes, and she is going to have vaginal dryness over a period of time, which is going to only get progressive. So we have to, give her the options of treatment profile and make her aware. Basically, awareness has to be there in her. And of course, when she's going through with the problem, she is going to come back to us, and then we'll deal according to what symptoms that she's showing.
Right. So that's beautiful. So as a gynecologist, it's again our responsibility. When she says, I'm good, my recovery is good, we also have to talk about her sexual life, when they can resume sex. And rightly said, at their zone of comfort, anywhere around 6 to 8 weeks later. But we have to understand there are certain conditions like adenomyosis, endometriosis, which give them a lot of deep dyspareunia. So she must have always had painful sex. She may not have had an active sexual life before. So we don't know about the quality of her sexual life in the past. So that is something we have to talk about and encourage her that she resumes. And if she has urogenital related dryness or something, it's important for us. And I think also with HRT, we have our reservations, whether we're giving local. So what is the HRT you would prefer to give if it is looking appropriate to start for vaginal dryness?
Are
It
you
should
asking
be a
that?
local.
I'm sorry. Can I ask Dr. Vidya to take this question? Yeah.
Sure.
Would you have reservations on
Yeah,
HRT?
yeah. So of course, I would like to have a background check on her past history and any family history of cancers or with her. And then local is always the best form of treatment for genitourinary symptoms. So we must start her with local estrogens. There are good gels that we are seeing. Avalon is one good thing, and conjugated estrogens. So I would like to start her on a daily basis because she's just 46. I think the Indian age group for menopause is 50. So I think HRT is quite a important role that it plays, not just in the genital tissue, but also in the bone and the heart. So we must, give her the knowledge, and local gels are playing wonderful role. So I will definitely, first choice would be estrogen. Also, there are always a second thought in women who undergo a hysterectomy. That is whether their vagina is capable to have the intercourse. As you very rightly said, that because of adenomyosis, she had painful sex, and that is deep-seated in her. So we will have to tell her that once she undergoes hysterectomy, she maintains the vaginal length. So there is not going to be any issue about the shortening, which is most of the time, patients do ask us about it. So I think local estrogen, there are a lot of preparations now with testosterone all come up, but I think for a genital issue, local estrogen would be my first choice.
Dr. Karthikeyan, since you are also part of my esteemed panelists, can I involve you in a hypothetical situation? Now, this lady comes back to me saying, you suggested to resume sex and you told me to use estrogens. Finally, I'm pain-free. But my husband, the last 2 years, we've not had quality sex at all. And my husband has become a diabetic. He's around 52 years old. And he seems to be having some problems. I think he's got erectile dysfunction. So I'm sending the husband to you. And as a couple, how would you help them to get back to their good sex life, which was there in the past? Dr. Karthikeyan?
Thank you, madam. So in this patient, we have to again identify what is the cause of the erectile dysfunction. So far we have been discussing about the painful sex along with the adenomyosis or endometriosis. So this could have led to a situation where this patient would not have had a pain-free sex in the last 2-3 years. And at that time, the patient has also got diabetes. So the distinction between psychogenic versus organic is a difficult question here. So we would like to talk to the husband and ask him 3 years before or 4 years before, how was your sex life? At the time were you having diabetes? All those things come to the picture. So at that point, if the husband says that my erections were okay, and even today my erections are okay, my morning erections are good, then we are probably dealing with a situation where probably the husband is now feeling left away. So he is not able to get the same interest or the same feel. That is why he is having erectile dysfunction. That is one thing. Second thing, we should also ask the husband what he thinks about this endometriosis or adenomyosis, whatever. Whether he fears that it is a cancer. Now, after hysterectomy, what is the thing which is going on in his mind? Is he afraid to do sex? So these two things are important. Plus, because of the organic component of diabetes, we will always do an erection assessment, supportive medicines, all those things will come to the picture. But the most important thing is what psychologically he feels about the situation. And is he also facing the dryness issue if at all it has started then, or previously whether she had dryness issue? These are the things we would like to revolve around.
So thank you so much. I just wanted to bring out the point that you should not leave the partner effect as well, because a lot of times we just think about the woman and the estrogen gel. Right now, this is a third patient. She's 41 years old. She's coming to our clinic along with her husband for termination of pregnancy. It's an unwanted pregnancy. She already has 2 children. She's deeply distressed and she keeps accusing the husband that it should not have happened, and this baby is a big mistake, and a lot of guilt that she allowed the sexual activity to happen. Unlike the movie Badai Ho, although it was an accidental pregnancy, the woman is very clear. She wants to continue the movie. But this woman has a lot of guilt and regret. So while you're offering the termination of pregnancy to reset their sexual life, to bring her out of that guilt and regret, of course, we're going to offer her contraception. So do you think such couples should be brought back to see if things have sorted out when they are emotionally disturbed, when the woman is emotionally disturbed about the termination of pregnancy? So can I request Dr. Sumati to take this question? Dr. Sumati?
can further sex life get affected? Naturally, the sex life will get affected because the guilt what she has, and mostly in this age they pour on the guilt and the complaining tone towards the partner. So I think we have to offer after the MTP, we have to discuss about the contraception, making both sit, and the discussion and offering will be really good.
So we have to make sure that we just don't offer the service. As gynecologists, we should make sure that things get back. And this is a platform to discuss safe sex, and that contraception is there, and not make her feel that termination of pregnancy. Sometimes they feel it's a huge crime that has happened. And we have to understand that bereavement counseling, we just can't say it's just an MTP. It's important for us to understand how it is affecting her emotional health. So I guess that follow-up is equally important. Thanks for bringing that point out, Dr. Sumati. Now, this is a 48-year-old lady. She feels her husband is not happy at the end of sexual intercourse. He's not satisfied. She's really upset about it. She's a middle-class woman. She's had 3 normal deliveries, and the third child is around 10 years old. And on examination, we find the vagina is lax, and the husband has been doing a lot of body shaming comments, and she's really upset. She comes to you and says, my marital disharmony is setting in the house. So, doctor, please help me. Dr. Deepa, although you're a cosmetic gynecologist, please understand, underline, she's a middle-class woman who doesn't have strong economical background. How are you going to help her?
As you said, it's already like 3 normal deliveries and lax vagina. See, but again, the only thing is like, first we actually just give her counseling because of the body shaming, which husband is doing, and because of psychologically she's really getting affected. First of all, I would really just give her some boost and just say, don't have to worry about it. And of course, when they come to me, obviously they're going to come for a solution. So I usually offer both surgical as well as non-surgical. As you said, vagina is very lax. So non-surgical, all these lasers or radio frequency or any energy-based devices wouldn't really work, because it doesn't give that much of effective. The only permanent solution which I offer for such patients is a surgical I do colpoperineoplasty for them, and that not only it gives the function back, as well as cosmetically also it's corrects it. Apart from that, most of the people when usually they come, body shaming is not only because of the loose vagina, also because of the body. Sometimes they have a lax over abdomen. So some patients who come and ask for tummy tuck or liposuction, and most commonly they have is a breast sagging. So sometimes that's the most common complaint. They come and say my husband always says your breast is so much of sagging, it doesn't look good, and you're out of shape, look at your tummy and everything. So overall, so nowadays a lot of people come for mommy makeovers, where we do a breast reduction, a breast lift with a tummy tuck up, a liposuction along with vaginal tightening. But for her, like you said, she's a very a middle class, but these are the things which can actually give her the solution. There is no non-surgical, I would say, for any of these. And if at all, if it's only mild laxity, yes, of course, we can give non-surgical lasers we can offer. But if it's such a laxity, only surgery can give her the permanent solution.
I think you gave that beautiful word, mommy makeover. So I guess surgical corrections would make a huge difference. And most gynecologists are reasonably good at doing that pelvic floor repair and retightening it. And we also have to look at her emotional factor, that even though we do a surgical correction, her mind should reset to be able to fix things right. And these are situations where the intimacy can be intimidated. It's a sensitive thing. So we have to bring in the couple, talk to them, counsel them, then offer them solution. If the husband is so serious about it, I'm sure he's going to spend for it. Now, this is our next case. She's a 52-year-old, very fit lady. She has no comorbid factors. She attained her natural menopause when she was around 45 years of age. Currently, she comes to the clinic with complaints of discharge and an altered smell. And she gives history on further exploring that she has vaginal dryness and painful penetration, and that she does not enjoy sex anymore, and it has become a very infrequent event in her life. So solutions, Dr. Vidya,
Yeah, I think we already discussed about this, that
Yes,
we
yes.
know that menopause carries the
Yes.
most complicated bothersome symptom of genitourinary syndrome. And the first symptom that patients come is dryness, loss of lubrication, and all this impacts their sexual health. So I think looking at her at 52, we know that she is a sure shot candidate for local application. And of course, estrogen, and there are a lot of intravaginal DHEA that has come around. So I would definitely go in for that. But along with that, counseling and giving her realistic goals, that these are progressive changes and you need to work on that.
Yes. So I think it's important as gynecologists, when we ask about the gynecological history, address how her sexual frequency is. Now, sexual frequency, I think most of us ask only for the infertile couple.
Yeah.
How often do you have sex in a week? I think it's important for us even to ask our midlife women, how often do you have sex? Is your sex life good? Are you satisfied and happy? Then maybe she will have that room. No, she might feel it as a very embarrassing question, but if she gets the confidentiality that her gynecologist is willing to discuss sex, she might come out with it. And it's basically the implicit model. No, we have to tell her it's not wrong to be romantic at 52. And as you rightly said, we have the estrogen gels, we have lubricants. And even if she says it's been a long time, doctor, I don't think I want to have sex again, it doesn't have to be necessarily intercourse. There's something called extracourse, continuing to show that intimacy and love should happen. And do you think there is room to talk about masturbation, Dr. Karthikeyan? Is it strictly a male field, or it can be brought about into the female purview as well, Dr. Karthikeyan?
Yeah, nowadays we are getting to know more about these things, and probably maybe I think Dr. Vidya would be the right person to answer about this. For the
Absolutely. I think I will definitely go with the what Dr. Karthikeyan said. And I've actually witnessed a patient who actually came. She has separated from her husband, and she has an aging mother whom she tried to open up, and her mother gave her the cultural issues that we are. So she really didn't know how to talk to. And when she came to me, and she really looked very distressed, and that's when she opened up. And I actually told her that it is time that you use your own hands and, masturbate. I actually told her what the whole anatomy of clitoris and explained the whole thing. And I not only told her about masturbation, told her about vibrators and to go on the net, find more details. So this is something that we have to open up with women who are not able to have a partner, and they're so socially bound that they cannot go out. So I think such women, we have to allow them to masturbate or use, as we say, sex toys to help them to do so.
I love you, Dr. Vidya, on post Valentine Day to be able to tell that women have a right to love, right?
Yes.
So, and also it's a point where we can talk about postmenopausal, so pelvic floor exercises, and keep their perineum protected. So menopause is a huge transition. It can affect their sexuality, and not all may be blessed to be able to have their partner right through the journey of life. But of course, there is wear and tear happening. And most of us don't take a good sexual history. In fact, even in our master health checkups, sexual health satisfaction is always not documented. Yeah. So I think this particular panel should be able to convey through Chennai Menopause Society to our listeners. Why don't we start addressing sexual health satisfaction? Because we may be able to help more women when sexual health issues are becoming a distress factor. Maybe it is insufficient stimulation, lack of lubrication, or the vascularity there changes. And so many changes affect in menopause. If you see head to foot, the women, we actually had all this discussed: backaches, joint pains, drooping breasts, sagging bellies, and then the vaginal itching and soreness. And very easily it can get, bruised when they have a dry intercourse and bone changes. Yeah. So I think the key aim of our panel is to help them to age gracefully and to adapt to the various changes in the body. So how far do you see HRT as an important recommendation? Dr. Sumati, do you think we should offer HRT as at least a short-term HRT for preventing these urogenital symptoms? Do you believe it giving HRT also for cardio protection? Or do you offer only if they complain?
Not as a primary prevention, but for genitourinary syndrome of menopause, that should be considered 100%.
Yes.
It's very important. And also just I wanted to, for an awareness sake, about the previous, the foul smelling when you just
yes.
screening, the cervical screen that has to be
Absolutely. Absolutely.
local therapy for sure.
Yes. Dr. Karthikeyan, where do you see usage of androgen therapy for reduced libido of women? Would you think it has a role in the woman as well?
Yeah. Actually speaking, there is an upcoming role. So as we see the newer meetings, we are now coming to understand that this may be one of the reasons for reduced libido. Means this can be one of the therapeutic options for reduced libido. Even though in India still we don't have a lot of like information about it, I'm sure the experts here would start using, or already are starting to use androgens for women.
So what is the dosage you would suggest and what is the route of therapy?
I don't give. So
Sustanon, huh?
no. For men we give, but for women we don't give. So
low dose, half tablet.
Okay. So it's an oral therapy. So the oral therapy of androgen, would it give them side effects of virilization?
Yes.
I think you have to keep a follow-up. You have to keep a follow-up.
It's something called androgel that also, I mean, has been tried just like half an hour, 1 hour, like, before the intercourse, they can just apply on the inner side of the thigh.
Yeah, it's like a gel form, I think.
Okay.
Gel form.
And also one more thing I want to add, for such patients, like, apart from HRT, like we have started giving all these PRP for vaginal rejuvenation along with lasers. It's beautifully working because in my practice, I very rarely give all these local estrogen therapy. Most of the people who come with like vaginal dryness or even severe hot flushes where they can't even sit or severe burning, I usually combine and give this PRP along with the laser every 2 weeks, along with like lifestyle modification, exercise, and like I give like phytoestrogens multivitamin. They're having a very good symptomatic relief.
So looking at that, Dr. Vidya, do you think actually these lubricants and moisturizers give the benefit? We tell the patient to use it. How far do you get a feedback? Yes, that helps me immensely. I'm talking about the postmenopause.
Yeah, when we are looking at counseling women with these kind of issues, first is the painful factor. Once you remove the pain, then you can always ask them to use the lubricant, because again, and as rightly said, that you have to allow the couple to practice. If you just give the treatment and they don't have penetrative sex, then you're not really doing any good to the couple. So along with them using these kind of lubricants or estrogen gel, there has to be a practice of the sexual intercourse, and only then can we get the results. So you cannot say one is separate from the other. It has to parallelly work together. So definitely lubricants and moisturizers do work only when we rejuvenate with the estrogen gel. So I would give them a temporary estrogen gel and then ask them to go. I think we have a gel called Acer that has come up now. It has got the phytoestrogen in it, which has benefited for a lot of women. At least I've had a good results with that.
Can you tell the name again, ma'am?
Iseren, ISEREN.
ISEREN.
Yeah.
Any comments on ospemifene for vulvovaginal atrophy? Anyone has tried that?
I have not really tried, but I've read about it, and it has a very agonist effect on the vulvovaginal part, and it has very minimal effect on the endometrium and the breast, and that's why it is the most upcoming and emerging SERMs. So yeah, and has a very positive effect on the bone strength.
Right. So I think we as gynecologists handling elderly women, we have to understand that various factors are to be addressed, and that's exactly what we have been looking at. And just not look at her body, but also her relationship issues. Is she having a partner who is willing to go through the whole exercise and reinvent their sexual life? And we have to be very careful with HRT. That's another comment most of my panelists made. You balance with the risks of clot, stroke, and cancer. And you help them. There's a huge variety of options, which we said, lubricants are available, local HRT, and we also brought in how cosmetic gynecology can also help in the situation, PRP therapy. So holistically, we have to address to be able to solve the problem. So I think sexual desire, to keep it intact, primarily it's a positive attitude, good health. Their young age sex should have been good. Basically, they should have enjoyed sex to be wanting to be good again in a menopausal age or in a perimenopausal age. And of course, it's not a singular activity. If it is going to be a couple, then you need to have an interested partner. And here We did have a talk about masturbation. Even if you're single, you should be fine if you know to masturbate. And emotional satisfaction is important. So if somebody is not having sex but is still emotionally satisfied, we don't have to bring them under the armamentarium of sexual dysfunction term. And the woman needs to be exercised, fit, and holistically healthy to be able to enjoy sexual health. So the whole theme of today's panel is, let's ask not just bowel and bladder history or any symptoms related to the vagina, but also ask them about sex. And a right to sex is a positive attitude. It gives so much of health benefits. No, basically compels them to be fit. It makes sure that their oral hygiene is good, their vaginal hygiene is good, they're taking care of their pelvic floor, doing their Kegels, they don't have incontinence problems or flatulence problems. So it sets so many things right. So with this, any special remarks my panelists would like to make, I would like to hear from them. Or else I would say a big thank you to Chennai Menopause Society for having given me this sudden upgrade from panelist to moderator. I enjoyed the flight journey with my panelists. Any comments?
Can I add 2 sentences?
Please, I would love to hear.
Rajapriya madam, you did a wonderful job.
Absolutely.
You passed with distinction.
Absolutely.
All the panelists are passing with distinction. And hope we really help people.
I think the take-home message, Dr. Rajapriya, you did an excellent job. And the take-home message today is what Dr. Shushma started with: break the silence. I think it is time that we as gynecologists should get together and allow the women to speak and break the silence.
Yes.
And I would like to thank Shanti madam for this beautiful panel. Not only for my patients, so many times it is going to help us also.
Yes, absolutely.
Thank you so much for having given me this opportunity. And I think the whole theme is we need to train ourselves to be able to take illicit sexual health and to be able to talk about sex comfortably. So we give them the room to talk back to us. No, unless we give the room, they will not open up. Yes, so thank you so much, Chennai Menopause Society. And I think I enjoyed doing this panel along with very good input from all my panelists.
Thank you. Thank you.
Thank you. Thank you, everybody.
Thank you.
Thank you.
Thank you so much, ma'am. With that, we've come to the end of our scientific sessions. We'll just review the quiz questions and answers before we go for the winner. So the first question was, painful sex can happen in all of the following conditions except hypertension. Which of the following are risk factors for secondary infertility in men except low sperm count, smoking, multiple fibroids? The answer was benign prostatic hyperplasia. The most important cause of reduced female orgasm in midlife? The answer is premature ejaculation. What term is used to describe the range of persistent and distressing sexual problems experienced by women during midlife and beyond? The answer is female sexual dysfunction. What percentage of women in midlife and beyond experience some form of sexual dysfunction? Roughly 50%. That's the answer. So we had a lot of people giving in the right answers. With 4 right answers, Dr. Chelapan Karupaya, he is the winner for the quiz today. He also asked a few questions during the first 2 sessions. So congratulations to Dr. Chelapan Karupaya for the being the quiz winner. I now invite Dr. Rajalakshmi to give the vote of thanks to all the delegates and the faculty.
Good evening, one and all. On behalf of Chennai Menopause Society, I would like to thank our Chief Gift, Dr. Shushma Chak Madam, and Guest of Honor, Dr. Yalini Shelvaraj Madam, for gracing this event in spite of their busy schedule. I would also like to thank thank our chairpersons and speakers for the excellent session, and also our delegates for making this webinar a great success. Thank you.
Thank you so much, ma'am. I think with that, we've come to the end. I think Shanti ma'am had to go for another personal commitment, so she had to hang up a little early. But thank you so much for patient listening. And I think it was a great session from all of you. Thank you so much.
Thank you. Thank you so much.
Thank you so much.